Hello, good morning. Keegan, I think you're ready to start now. I think Prof. Saklani will join us shortly. So good morning, everyone. It is my honor and privilege today to welcome you all on behalf of the Caribbean chapter of the AHPBA to our second annual HPB Surgical Oncology Conference. My name is Dr. Amiel Ara, and I'll be the moderator for today's meeting. Before we embark on today's proceedings, I would like to invite our chapter president, Professor Shamir Karich, to address those in attendance. Prof. Karich, you can go ahead.
Thank you, Dr. Ara. Friends, colleagues, welcome to our meeting today. This is the 7th annual meeting of our Caribbean chapter of the Americas Hepatopancreaticobiliary Association. And it is indeed my honor to welcome some special guests today. Today we have Professor Michael D'Angelica, who is the president of the Americas Hepatopancreaticobiliary Association. Prof. Chad Ball, who is president of the Canadian chapter of the AHPBA, and Prof. Ajit Sirwandino, who is president of the European chapter of the AHPBA. We also have Prof. Saklani from the Indian chapter, and two of our own homegrown experts, Dr. Tanzila Barrow and Nazreen Bim. And to all other distinguished guests, welcome to this 7th annual meeting. Now, we all know that the Caribbean has a very large footprint. It's made up of 17 independent English-speaking countries with a cumulative population of 7.5 million persons. Many of these are small island states, and each of us have different strengths and different challenges. And this was the reason that in 2015, we approached the AHPBA to have the Caribbean chapter inaugurated, because we wanted to have a singular focus to increase the awareness of hepatobiliary and pancreatic diseases, to foster research, and to improve outcomes from treatment of these diseases. Now, on one hand, while we're disappointed that we cannot extend our traditional Caribbean greeting so that our guests can enjoy the warmth of the Caribbean people, and see the beauty of our region, we still welcome this opportunity to collaborate with our colleagues from across the globe. And as you will see, we've put together quite an exciting program of regional and international speakers. Before we start today's meeting, though, I would like to extend a special thank you to the local organizing committee for making this meeting a reality. We want to recognize Dr. Wesley Francis, who is our immediate past president, Dr. Ravi Maraj, our vice president, the secretary, Dr. Amiel Aro, and hardworking members of the executive, Dr. Greg Padmore, Fawaz Mohammed, and Don Major, who have made this program a reality. Now, without delaying the meeting any further, I welcome you to sit back and enjoy this program that we've prepared to you today. And I'll hand you over to our moderator, Dr. Aro, for instructions and to get the program started. Dr. Aro, please proceed.
Okay, thank you for that, Prof. Kawich. So we'll get started right away with our first speaker. Our first esteemed speaker is Professor Ajit Siriwadena. Professor Siriwadena studied medicine at the University of Manchester and then trained in general and hepatobiliary surgery in Manchester, Edinburgh, Richmond, USA, and with Professor Henry Bismuth in Paris. He subsequently moved to a position as consultant surgeon at the Manchester Royal Infirmary in 1999 and was appointed the Professor of Hepatobiliary Surgery at the University of Manchester in 2008. In 2007, he received the prestigious Silver Scalpel Award as the best surgical trainer in the UK. His clinical practice is in hepatopancreaticobiliary oncological surgery with a clinical focus on liver and pancreas cancer surgery. His research interests include pancreatic inflammatory disease and metastatic colorectal cancer. He was a Congress president for the European chapter of the AHPBA in 2015 and the current president-elect of the AHPBA. Professor, we humbly invite you to now deliver your much anticipated address on the management of hilar cholangiocarcinoma. Thank you.
Thank you very much for that introduction. Shall I just start screen sharing?
Yeah, you should be able to share your screen now.
Okay. Can you all see the screen?
Yeah, we're seeing the screen, Prof.
Okay, good. So I'll start, okay? So first of all, thank you very much, Emil, for those kind words, and thank you in particular to Shamir for the invitation and the opportunity to participate in this meeting. I would have loved to have been there in person, but sadly we can't. So my topic, without any further ado, is the surgical management of perihilar cholangiocarcinoma. I'm going to do a little focused overview and then hone down on the practical management of this condition. I'm not going to talk about liver transplantation because that really is a separate topic and it would take away from the practical management, which I want to focus on. So in terms of outline, I'm going to talk a little bit about types of cholangiocarcinoma, then focus down on perihilar cholangiocarcinoma, very briefly talk about the molecular biology, and then focus on the incidence, clinical presentation, and practical management. Okay, so in terms of types of cholangiocarcinoma, we know that cholangiocarcinoma is thought to arise from the epithelial lining, so the cholangiocytes which line the bile duct epithelium, categorized traditionally according to anatomical location into three: intrahepatic, perihilar, and distal. Each subtype has a distinct epidemiology and biology. Now, there's an excellent consensus.
Professor, apologies.
Yep.
Sorry, we're still seeing the title screen, and I'm not sure if.
Oh, okay. 1 second. Let me see. I'll stop share.
I think maybe if you go to present, yeah, I think you should be.
Ajit, I think you have to put it in presenter mode.
Yeah.
Does that work?
In presenter mode, but share the presentation that is open. This is actually the main window you're sharing right now.
Okay. So, one second.
You'll see two PowerPoint windows. You're looking at the full screen version and share that one.
Yeah. Does that work? Has it moved now?
No, you may need to stop the share and restart the share.
Yeah, okay, I'll stop the
Yeah?
share and
Right.
restart, okay?
Yeah, thank you.
Okay. How about that?
There you go.
Yay, okay. So I'm getting a thumbs up from Mike DeAngelica. So I'll just go back a little bit in case you missed all that. So we're going to focus on the surgical management of perihilar cholangiocarcinoma. I'm not going to talk about liver transplantation. In outline, we're going to talk a little bit about the types, focus on perihilar cholangiocarcinoma, a little discussion of the molecular biology, and then really the focus is on the practical management of the condition. And I'm going to share my surgical experience over the last 10 years or so. So in types, we know traditionally that there are three types, intrahepatic, perihilar, and distal. Each has a distinct epidemiology, biology, and a clinical management pattern. This is the consensus which I've referred to quite broadly during my talk. This is a predominantly European, but not exclusively European consensus on diagnosis and management of perihilar cholangiocarcinoma. It focuses a lot on the genetics of the disease, which I'm not going to emphasize a lot. So this is an illustration from that. One of the things which has happened is that ICD-11, due to be implemented in 2021, for the first time classifies 4 types of cholangiocarcinoma. And that's a step forward because up to ICD-10, they used to be classified as intrahepatic and extrahepatic. So now we've got intrahepatic, perihilar, which is from the second order bifurcation to just above the cystic duct insertion point. Distal cholangiocarcinoma, so everything below that is a distal cholangiocarcinoma, and a recognition for the first time of the special type, which is a mixture of HCC and CCA. So those are the 4 types which are recognized in the WHO classification ICD-11. If we focus on perihilar cholangiocarcinoma, the eponymous term Klatskin derived from the first description of this by the American histopathologist it's a Russian name of Russian descent, Gerald Klatskin. In fact, the first description was by Altmaier from Cincinnati. Both described a sclerosing tumor of the hilus. And I've read Klatskin's paper, and it is a description which is true to this date, which is it's of a tumor at the bifurcation of the hepatic ducts with unilateral atrophy and ductal crowding. So it's a very classic description. In terms of the molecular biology, because we're a surgical audience, I'm not going to focus a lot on this. I've just got 3 points to make, which are, I think, of practical relevance. Firstly, perihilar cholangiocarcinomas have a characteristic profile of driver mutations. So these are somatic mutations within the tumor with a high frequency of KRAS, TP3, TP53, and SMAD4. These are all tumors, or these are all mutations which you can detect on circulating tumor DNA tests. So I think it moves us forward to what's called liquid biopsy or non-lesional biopsy for diagnosis, which the PHCC, I think, will be important going forwards. 2 other interesting points. Perihilar cholangiocarcinomas don't signal by the fibroblast growth factor pathway, and thus the expression of these targetable FGFR2 mutations is a hallmark of intrahepatic cholangiocarcinoma. So it indicates that there is a genuine biological distinction between IHCCA and perihilar cholangiocarcinoma. There's also a genomic association with liver fluke infestation, which I think is interesting, with fluke-positive tumors showing a much higher mutation rate, suggesting that irritation of the epithelium by fluke tumors causes perihilar cholangiocarcinoma, and this may be one of the reasons for the wide geographical variation in incidence. So there is a huge variation from 2 per 100,000 in Europe to 85 per 100,000 in parts of northern Thailand and that part of the Southeast Asian peninsula. The Caribbean, according to the WHO, actually isn't all that high, so one good thing for you. Typically, we present with painless obstructive jaundice. Occasionally, a perihilar stricturing lesion will be discovered incidentally in a non-jaundiced patient. So what about the management? So surgical resection is regarded as the optimum treatment, but typically this is only feasible in about 10% of patients. I'm not going to focus on the 90% who don't have resection, but it's just important that we emphasize that they're not in any way less important. So management here relies on diagnosis, getting the accurate diagnosis, typically on cross-sectional imaging with a triple phase contrast CT or contrast MR, relief of jaundice, assessment of suitability for surgical resection, and then optimal palliation. So this is a CT scan showing that a typical, actually a locally advanced perihilar cholangiocarcinoma, so a tumor at the hilus, which shows as a dark area in the contrast CT, with some left lobe atrophy and early ductal crowding on the left side. So how best to relieve jaundice? And there are lots of studies on this, but there's really only one that's worth talking about. This one stands over all the others. This is Thomas van Hulijk's Dutch randomized controlled trial of endoscopic versus percutaneous biliary drainage for patients with resectable perihilar cholangiocarcinoma. A lot of lessons from this study. So 4 centers in Holland, I think there are only about 6 or 7 that do this kind of surgery. So 4 of the busiest centers, including the Amsterdam Medical Center and Rotterdam, took almost 3 and a bit years to recruit 261 patients with perihilar cholangiocarcinoma. 207 were excluded, typically because of metastases or because they were unfit for surgery. That came down to 27 having endoscopic drainage and 27 percutaneous. This is a 1-to-1 randomization. Of those, 22 in the endoscopic arm went on to have surgery and 20 in the percutaneous arm. So tiny numbers, really. Primary outcome measure was a sensible one for this kind of study, which was number of severe drainage-related complications. If we look at their data, predominantly type 3 or 4 perihilar cholangiocarcinoma, as you would expect. In terms of complications, up to the point of operation, there is no difference. What was striking was the difference in mortality within 90 days of surgery. This was statistically significant with a 3-fold increased risk of death. The authors concluded that the small numbers mean that there's a high possibility of type 1 error, but the study was stopped correctly because of that. What I hadn't appreciated, and I read this paper again in preparation of this talk, was that successful drainage was about the same, maybe a little bit more in the percutaneous in the PTC group, but the crossover was a big difference. And I hadn't picked that up when I first read this paper, that 56% of patients having endoscopic drainage needed a PTC, whereas only 1 patient having a PTC needed a subsequent endoscopic drainage. So the authors concluded the trial was stopped prematurely because of the higher mortality. Post-drainage complication rates were similar. And although the authors call for more studies to be done urgently, I don't think that's correct. I'm involved with the UK National sort of HPB study priority assessment group, and I don't think this would be a priority. I think the time for looking at trials of endoscopic versus percutaneous drainage is past. I think we'd conclude that both techniques remain feasible, and I think you do what you have experience within your center, but you can also develop expertise, and we predominantly use PTC for patients who are going to have a resection. So how do we undertake the practical management of the jaundice patient with a perihilar stricture? So all patients, you'd have an ultrasound scan, ideally a triple phase CT before biliary intervention, and it's important to emphasize that the diagnosis has to happen in parallel with the clinical care. You can't do the diagnosis first and then the clinical care. So people need intravenous fluids, analgesia, correction of coagulopathy. That has to happen from the time people hit the door. This is a classification. It's probably globally the most familiar. I see Mike DeAngelico on the call, and I think the Bloomgard classification is actually probably better. It takes into account vascular involvement and lobar atrophy, but I've gone with this because this is what's typically most widely used, the 1 to 4 classification. Most of you will be familiar with that. So in inoperable disease, patients will typically display separated ducts on the right and left side. Therefore, an ERCP may not adequately drain both ducts, both sides, and the risk there is that you introduce contrast into one side of the hemiliver, which then remains undrained, which can be a disaster. Probably you'd think about percutaneous transhepatic biliary drainage, brushings in a patient who's fit for chemotherapy. You can use a metal stent, and then palliative chemotherapy in patients with an ECOG performance of less than 2. The rare type 1 stricture, this is a common channel proximal to the stricture, and therefore it can be drained endoscopically. It's very rare. Most commonly, we see this as a late complication after gallbladder surgery, and then there's a whole debate as to is this a type 1 perihilar cholangiocarcinoma or a benign stricture. So there's a whole discussion to go about that. But an endoscopic stent there can drain both sides. For types 3 and 4, it's essentially the same management. So you may well need bilateral external drains, ideally internal external drainage, brushings, clamp the external drain, check cholangiogram, and internalize and refer for chemotherapy. So let's focus now on the practical management of the patient with a potentially resectable perihilar cholangiocarcinoma. So 3 components. We think about diagnosis, normalization of bilirubin, and preparation of the future remnant liver. So this is one, and in the NHS, we're a centre that serves the northwest of England. We have patients that come to us from about 150, 200 miles away. And if you have a resectable perihilar cholangiocarcinoma, and I guess this is going to be the same pretty much across the globe, we need to take control of that patient's management. So we don't want other people doing various interventions, and we have to do that fairly politely, but also fairly firmly. So we'd have a contrast enhanced CT of the thorax, the abdomen, and the pelvis, a contrast MR prior to biliary intervention if possible. You can get additional diagnostic information if the patient has had a PTC. There's a loss of value in that. And then things that we do in Manchester, which are probably not standard, we have recently taken to using FDG PET as a staging modality in these patients. That is a non-standard test, and I don't think that has to be done globally. And pre-pandemic, we used cardiopulmonary exercise testing as an assessment of cardiac and respiratory morbidity. And again, I think you'd have to regard that as a non-standard test. What about normalization of bilirubin? So our steps are, the first step is percutaneous drainage of the future remnant liver. In other words, the lobe that's going to stay behind. Ideally, we'd use an internal external drain so that allows the external component to be capped, because there is evidence that this external loss of bile and the disruption of the biliary enteric circulation increases postoperative infective complications. Drainage of the to-be resected lobe may be required if the bilirubin doesn't fall. I'd probably give that a week to 10 days as a gap between the two. And the drainage of the right lobe may also be indicated if you're going to do a right lobe portal vein embolization. Now, in terms of portal vein embolization, for a left hepatectomy, relatively little is gained by left-sided portal vein embolization because most of the bulk of the human liver is on the right lobe. In contrast, right portal vein embolization is something which is useful. It can be extended up to the segment 4B branches. It's important to have a close liaison with your interventional radiologist, and we ask them to use gel for embolization because we're planning a staple transection of some of those pedicle branches, and the stapler will go crunch on the coils if they've used coils. And I think if you're going to have a right portal vein embolization, we will then have pre-procedure drainage of the right biliary tree. Otherwise, they're puncturing for portal vein embolization through an obstructed biliary tree and potentially introducing infection into that. Okay, and let's focus now on the practice of hepatic resection for perihilar cholangiocarcinoma. And this is what we do. I'm going to highlight some of the areas where we may differ from what other centers do. And I'm not recommending any specific change, but this is what we do. So anesthetic preparation is standard: GA, epidural, arterial line, central line. We'll have limited intravenous fluid infusion. I don't make a big issue about pharmacological procedures to lower the CVP, because if you have limited intravenous fluid infusion after an overnight fast, by and large, you'll end up with a low CVP. If you lower the CVP any further than that, then there's a risk of systemic hypotension in patients who've generally had an obstructed liver. We don't use prior laparoscopy, and that is one of those things which we are now going to report in a symposium, actually in an edition of Cancers run by Bas Groot-Kerkamp, because it's one of those things which I think is generally accepted as something that you should do. We haven't done it for 10 years or more, and I'm going to show our data without that. The standard, we don't do these laparoscopically. We do a lot of laparoscopic liver surgery, as Fawaz can attest to, but cholangiocarcinoma is pretty much always an open operation. So an epigastric midline incision with a right transverse extension, fixed costal margin retraction, These slides are courtesy of my friend Thomas van Hulen. It's a very pretty slide, which is why I always use it. So first step is a laparotomy to exclude metastatic disease. Then the focus of resection is on dissection of the liver hilus. So we will very quickly mobilize. I'm going to talk about a right-sided resection. So we'll mobilize the right lobe. There's no particular requirement here for extrahepatic control of the right hepatic vein or division of the hepatic cable ligament. You can do those things if you need to, but often don't, because the resection, the interest is at the hilus. Then we're talking about hyaline-lymphadenectomy, and these are the nodal stations that need to go. So taking out the bile duct takes out most of those 12 stations around the bile duct. It won't take out the fleshy node at the base of the portal vein on the right side, and the sausage-shaped node 8 needs to go together with the station 9 node, and then you can see, usually you can see the origin of the splenic artery. So that's not a particularly complex step. It just has to be done slowly and carefully. That's a radical hyaline-lymphadenectomy. Then we get to a kind of high noon moment. We tend to talk about this in surgery because we're dividing the bile duct. Once the bile duct is divided, then there's no going back. You have to do something. I divide the bile duct flush with the upper border of the pancreas, just behind the duodenum. It's important not to burrow into the pancreas, because if you do, there's a very high possibility of actually putting traction on the main pancreatic duct and damaging that, and then you'll get a nasty pancreatic leak. You can send a frozen section from there. I stopped doing that some years ago because I don't think it's particularly logical on the system of you're only going to do a test if it changes your practice. I'm not going to do a hepatopancreatoduodenectomy, although technically that's a fairly easy thing to do in this situation, because you've got a plane anterior to the portal vein, you've got the gastroduodenal artery demonstrated. You could do a hepatopancreatoduodenectomy, but I wouldn't recommend it in that situation because it's a big physiological hit. If your hepatic artery, if your cystic duct, if your common bile duct is macroscopically involved by tumor, that's not a situation for doing a resection. So what we're looking for with a frozen section is microscopic perineural invasion, which I think, I'm going to accept. I'm not going to do a frozen section to do for that one. So then we peel the bile duct proximally up to the hilus. We'd ligate and divide the right hepatic artery. Nowadays, I leave a couple of hemologs on the right hepatic artery and ligate and divide the right portal vein. If there's space, and if you can get clear of the branch to the caudate, there you can staple that. If not, I'd ligate that in continuity and staple it inside the liver during the transection. Mobilize the caudate with the mobilization of the right hemiliver. Look for the broad caudate branch going back from the caudate into the cava. That's the only thing you have to be a little careful of. Mark a transection line just the right of the fossa, and then hepatectomy technique is a personal preference. I learned to use the Cousa with ligate. Laparoscopically, we use a sealer, but for open liver surgery, Cousa with Liger clips and a vascular stapler, and the reconstruction is by hepatic vaginectomy. So I thought, having said some of those things, I should share my results. So this is me. This is the paper which is going to be in Cancer soon. So our rationale for not using laparoscopy was that higher resolution CT will show evidence of locally advanced cancer, metastases, and ascites. Diagnostic laparoscopy, in the way it's used, doesn't typically provide any additional information on the state of the vasculature, because you really need to assess the freedom from cancer of the vasculature to the future remnant lobe, which is a manual thing. And it doesn't provide much additional information to CT or nodal involvement. I'm not recommending here that people who use staging laparoscopy stop it. I think if it's part of your practice, carry on doing it. I'm just saying this is what we have done. And small volume peritoneal metastatic disease, typically you can pick that up as a mental nodules on CT. This is very similar to laparoscopy and laparoscopic ultrasound for pancreas cancer, which 10 years ago we did as standard, and now it's disappeared. So this is a consecutive series of 32 patients, all operated on by me over a 13-year period. So it shows this is a vanishingly rare cancer to come to surgery for a population of about 3.2 million. We probably have some spillover from the western and eastern parts of our catchment area, but it's 13 patients. To contextualize the data, that's 487 liver resections during that period, of which 176 were hemihepatectomy or beyond. This is the profile. So 64 was the median age. They had quite a high bilirubin on admission. We took a little while to normalize, about 33 days to normalize the bilirubin, try and get the operation done relatively quickly. Everybody had a pre-op CT. Only 75%, I was surprised at that, had a pre-op MR, and I think that's just because of the older data that we've included. Nowadays, everybody would have a CT and an MR, and we use a combination of PTC and ERCP for drainage. This is a slightly cumbersome slide. So 4 patients were thought preoperatively to have a type 2 cholangiocarcinoma. Operatively, that was confirmed in 3. 1 had a 3A. So it took us down to a final total of 3. It's that kind of thing. I'm going to just focus on the operations. A typical spread of operations for perihilar cholangiocarcinoma surgery. 1 patient had a non-resectional laparotomy because of nodal disease, together with a relatively small liver remnant, which I think in hindsight we should have modified beforehand. That was about 8 years ago. In terms of technical detail, I don't think there's anything particularly exciting. They are long operations. 12 patients need an intraoperative transfusion. The median transfusion requirement was 0. As with most surgeons' careers, the second half of this period has much less use of blood transfusion, much shorter Pringle times, and much shorter transections. So I guess, if I'm honest, I have to say I've got better at doing this over the last 10 years. These are the complication profiles. So the all-cause post-operative mortality within 90 days was 0. And only 11 patients received adjuvant chemotherapy, which is, again, it's an indication of the time period of the study. The results, the confidence interval doesn't really display there, but it's a broad confidence interval because it's a small series. So median time to recurrence was 14 months, median survival was 25 months, but the upper limit of confidence interval not reached because these are data which include patients who've had their surgery recently. So let's look now at neoadjuvant and adjuvant chemotherapy lastly. So neoadjuvant chemotherapy is logical because it's used for a lot of GI cancers. It's difficult to conduct a study of this. So preoperative tissue confirmation of malignancy, which would be required in the UK for giving chemotherapy, is really difficult. It may well be the case that circulating tumor DNA could be used as a surrogate in the future. And the other thing that's difficult is that relief of jaundice can take 3 to 4 weeks, and then chemotherapy may be given to patients with an external drain in situ, and oncologists aren't happy to do that. NeoPAC, which was a proposal, was to look at the Mayo Clinic chemoradiotherapy protocol. So the Mayo Clinic protocol was chemoradiotherapy and liver transplantation. And my proposal was to look at the chemoradio protocol with liver resection. It's too complex to do, and it's currently discontinued. Let's look at adjuvant chemotherapy. There are several good studies. I'm just going to focus on John Primrose's BILCAP. This was the ASCO launch slide of BILCAP, which is a randomized controlled trial of capecitabine versus versus nothing. You can see that actually the survival curves do parallel each other, but there was a survival benefit, 36 versus 51 months for capecitabine, which didn't hit statistical significance, but on the basis of that, NCCN and ASCO and in the UK, NICE have all recommended that adjuvant capecitabine become the standard of care for patients who have a resected perihilar cholangiocarcinoma. Just worthwhile, and this may not project all that well, but BILCAP focused on all patients with cholangiocarcinoma, not just perihilar cholangiocarcinoma. So it's a fairly small cohort in BILCAP that actually had perihilar cholangiocarcinoma, and in that cohort, the forest plot actually favors observation, for what that's worth. PACTICA-1 is the current big European multinational multi-center study. They plan to recruit 781 patients for this with a biobanking translational arm. So that CISGEM started out as CISGEM versus observation alone because BILCAP's results were published after launch. The placebo arm has now gone and it's been replaced with so it wasn't placebo, the no intervention arm has now gone and it's been replaced with a capecitabine arm. And because of other data, there's also now another randomization in there for patients who are R1 positive. They will get radiotherapy for their resection. So in conclusion, perihilar cholangiocarcinoma is a rare tumor. The majority aren't resectable by surgery. It's important that we don't forget those patients because only 10% of patients have disease that can be removed. Surgery itself requires near faultless preoperative preparation. The operation itself is possibly the most complex non-transplant adult hepatobiliary operation. And I think what I've tried to get people to think about is that the management of rare cancers has much dogma, often supported by little evidence. If what you do works for you, I'm not suggesting that you change it, but if you're a young surgeon starting out in your practice, think about what you do, what you're wanting to achieve. And as a general principle, it's worthwhile avoiding over radical surgery. So we looked at ALPS a few years ago and decided not to do that because of the mortality. We looked at hepatopancreatidodenectomy, which is technically feasible, but has a very high morbidity. So morbidity high, mortality high, and the meaningful benefit to patients in terms of survival and improvement in quality of life is very low. Thanks very much for your attention. Sorry, I had to put Manchester United in there somewhere.
Thank you very much, Prof, for what was a quite profound yet practical approach to what is otherwise quite a difficult cancer to manage. Are there any questions from the audience that we will take briefly? Please bear in mind, if there are any questions along the way, feel free to post them on the chat and we could always tackle them later on during the break or coming on to the end of the today's proceedings. Prof. Sirodina, I don't know if you would mind taking a quick question from myself, if there are no others. As you mentioned, you know, and I think even within our local setting, a lot of these patients do present at a point where surgery isn't going to be that helpful in terms of achieving a cure. Are things like, well, especially for unresectable patients, I would say things like chemoembolization or radioembolization, these kind of things. Is there any hope in those, modalities in terms of prolonging any survival of patients unresectable, or is there even the possibility of converting to resectable disease?
Thank you. That's a good question. So, majority with this, 90% are going to have unresectable disease. So I think the first step, they're different to pancreatic cancer patients. So pancreatic cancer, if you've got an unresectable pancreas cancer, you really have to get stent and chemotherapy going. Cholangiocarcinomas can keep going for a long time. That patient of mine who had the non-resectional laparotomy lived for about 18 months after his operation, suggesting that he was possibly borderline resectable when he first presented. So it's worthwhile, therefore, to put effort into relieving the jaundice, because if you relieve the jaundice, then people can live longer. So that's the first step, and that is either PTC or ERCP. People have looked at a radioembolization CERT with yttrium microspheres in patients with perihilar cholangiocarcinoma. It doesn't make a big difference. What does seem to be promising is brachytherapy with actually delivery of a radioactive material to the tumor itself directly, and that seems relatively promising. It's the trouble with that is it's not hugely evaluated. It's only available in a few centers. So if you don't have that, I think concentrate on getting the patient free of jaundice. And then I think there is some benefit in simple palliative chemotherapy. So capecitabine, you can take as a tablet. And I think that's probably worth the chase.
Okay, thank you very much, Professor Siriwaddina. Before we move on, are there any other questions? Okay, again, you can feel free to post questions on the chat and we can tackle them later on.
Okay.
So seeing as there, sorry, someone had a question? No, okay. So seeing as there are no further questions, we will move on to our next speaker. Dr. Michael D'Angelica is a board-certified surgical oncologist with expertise in treating cancers of the liver, bile ducts, gallbladder, and pancreas. Dr. D'Angelica earned his MD at the Tufts University School of Medicine in 1993, followed by a residency at the University of Connecticut Integrated General Surgery in 2000. He did a research fellowship at the Memorial Sloan Kettering Cancer Center from 1995 to 97, serving as the Chief Administrative Fellow in 1996 and 97, and did his clinical fellowship at Sloan Kettering from 2000 to 2002, where he currently works in the Department of Surgery, Hepatopancreatidobiliary Service. In addition to being the current president of the AHPBA, He belongs to several other professional societies, including the American College of Surgeons, Society of Surgical Oncology, Society of Surgery for the Alimentary Tract, and the Yukon Surgical Society. It gives me great pleasure to introduce Dr. D'Angelica, who will enlighten us today with a talk on the review of liver anatomy. Thank you, Dr. D'Angelica. You could start when you're ready.
Can you all hear me? Uh-oh.
Yeah, coming through loud and clear.
Okay,
Yes,
thank
we're
you. Thank you. There we go. And the slide is okay?
Yes.
Thank you.
Yeah.
Okay. So first of all, thank you very much for the invitation. I will be redundant and say that, of course, we would much rather have been there having a lovely evening the night before this. I was considering dancing to the music you were playing earlier to get in the mood. It is on the behalf of the AHPBA, of course, we are very happy to support the local chapters and are so proud of all of the accomplishments in the development of this subspecialty within the multiple chapters in the AHPBA. Having said that, I will go on to talk about basic liver anatomy, which I have to say, most of the time I talk about cancer, it's quite a pleasure to be asked to go back to what I guess I would call the basics and discuss liver anatomy, because if you're going to be a liver surgeon, as I will try to explain to you, you have to understand a lot of details of the anatomy in order to be an effective surgeon. I will also say that there is no way in 20 minutes you will walk away from this lecture completely understanding liver anatomy, but hopefully I'll give you a guide, at least as a way to think about liver anatomy, some of the basic principles, and certainly for the people who are not experienced liver surgeons, a way to go off and start studying this and understanding. So this is the way I learned liver anatomy when I was in medical school in the early 1990s, which was extremely rudimentary and not informative to anybody who was going to operate on a liver. You can see that they describe the right lobe actually involving what anatomically involves some of the left lobe. Words like quadrate lobe and things like this were not very helpful. And this was early American descriptions of lobar anatomy of the liver. But based on a number of studies, primarily Quinaud and some American anatomists, Goldsmith and Woodburn, we started to appreciate there was much more complexity inside the liver. The problem with the liver, of course, is that you look at it and there really aren't very many external markings as to where these segments and vessels run. And ultimately, the challenge to the liver surgeon is to expose this anatomy, which is not easy when you're trying to expose anatomy within a solid or semi-solid organ. But we did start to appreciate the segmental anatomy of the liver, which hopefully I will point out to you is extremely important to understand. And I would say if you don't understand the segmental anatomy of the liver, you probably are not qualified to do liver surgery. So I'm going to spend a minute or two on this slide because this really does summarize hepatic anatomy. And I think the easiest way to think about it is these three terms: caesurae, sectors, and segments. You can put any word you want on these, and I'm not sure the actual term matters as long as you understand the principle. But the caesurae are basically defined by the hepatic veins. And then they divide into sectors, which among themselves have segments. So in the simplest way, the middle hepatic vein runs straight through the center of the liver and divides the liver into a right hemiliver and a left hemiliver. You can see the segmental numbers there. And in the right lobe, the right hepatic vein has the right caesura, which divides the right liver into an anterior and posterior sector, each having their own segments. Again, I can give you the numbers, which are very obviously written here, but that's not the key. This is quite simple. And honestly, the most important part of this is where these veins run. There are planes around these veins inside the liver. And once you start developing experience operating on the liver, you begin to appreciate those intrahepatic planes. So the right liver is divided to the centrally as the middle hepatic vein, then an anterior and posterior sector, each divided into two segments. I would say the left liver is a little more complicated. And there are really two ways to think about the left liver. If you actually look at Quinaud's original description and you really understand the anatomy of the left hepatic vein, it divides the left liver into a lateral and medial segment. And the lateral segment is only segment 2, 3, and 4, the anterior segments. Now, sector, excuse me. But the truth is we don't think about it that way because it's not a very practical way to think about it. In fact, the umbilical fissure where the left inflow vessel runs divides it into a segment 4 and a left lateral segment. I think you can think about it either way, but you should appreciate that Quinaud's original description was really a little different than we practically use it. The other thing to appreciate is that the inflow vessels, which of course inside the liver are packaged as what we call a pedicle, with invaginated peritoneum or Glissen's capsule, and will provide branches to each of these segments, but how they branch and how they get there is extremely variable. I think this picture, of course, is a very simplified, oversimplified version of all of this. I think one of the biggest problems and one of the biggest sources of confusion is terminology. And I don't want you to read all of this, but I think you can call the right lobe, which I historically called it, or the right hemiliver or the right liver. You can now, using some Brisbane terminology, instead of the anterior sector, which Quinaud referred to, or you call it the anterior section. And again, I got to the differences between lateral and medial sectors originally described by Quinaud, and then medial and lateral sections now currently described. And then there are many segmental combinations which have no names, but are segments that can be resected together. And I think if I were to give you one basic principle, if you're in doubt about the right terminology, simply use the segment numbers. If I say to a liver surgeon, I'm resecting segments 2 and 3, they know what that means. Well, that could be the left lateral segment, left lateral section, any number of terms. Just put the numbers in, and that is probably the common denominator by which we communicate liver anatomy. So again, this is the way to think about a liver. The veins dividing up into major sectors of the liver. Within each sector, there are segments with inflow and outflow branches. There is incredible detail to this, which 20 minutes does not allow me to go into. But within each segment, you can start to appreciate on every scan and every patient what the inflow is, what the outflow is. If you resect that segment and take that inflow and outflow vessels, what consequences that may actually have. And so you can start to get a sense of how complicated this can be when you start thinking about segmental liver surgery. Now, within all of this, there is one very important part of the liver that is not really described. It's almost like it's a separate organ, but of course it's known as segment 1, or the caudate lobe of the liver. And if you're going to do liver surgery, and as you just heard, if you're going to do surgery on hilar cholangiocarcinomas, typically you remove the caudate en bloc with whatever side of the liver you're removing along with the bile duct. And so knowledge of the caudate lobe is very important. Posteriorly, it has this caval ligament that runs from the left to the right side, and it's critical to understand if you're mobilizing the right lobe of the liver or the left side of the caudate. The inflow comes from both the left and right, and if you're dissecting the left portal vein, you typically see a branch going right into the caudate along the left side of the cava into the caudate branch. But there is also a branch off the right portal vein to what we typically call the caudate process, or the right side of the caudate. And the drainage, the venous drainage, as you can see in this cross-sectional view, is directly into the vena cava. And mobilizing the caudate for any kind, either an isolated caudate resection or an en bloc resection with a right or left lobe, requires serial dissection either from the right or the left, taking these. And some of these branches back here, there is typically one very large branch, which will not be well managed with a tie. It either requires a suture or a stapler if you can manage it. But understanding the proximity to the left portal vein, actually the left hepatic and middle hepatic vein, which are quite close, it requires a lot of study, and this is a complicated part of the body. So I'm not going to go through every one of these, but I've drawn out the segments on a CAT scan because the real challenge for the liver surgeon is to look at a patient, decide they are suitable for an operation for whatever the diagnosis is, then look at a scan, decide where the tumor is, what resection you do, and then translate that into an operation in the liver. And that sounds like a simple process, but it's an extremely complicated process and very challenging, requiring a lot of experience. But this, when I look at a liver, this is exactly what I see. So when I look over here, I immediately see the right hepatic vein. I know that medial to that is segment 8 with The inflow branch is sitting right here. I know segment 7 is posterior to that. You can see that the caudate extends well into the center part of the liver. And likewise, you see similar things. And this is exactly how I look at a liver. You can see the segment 2 and 3 inflow pedicles with the left hepatic vein here. This is, in my mind, something that is automatic, but that's after looking at thousands and thousands and thousands of CAT scans over the years. And you can see this is the way a liver CAT scan should look, or MRI, whatever imaging you're looking at, to anybody who's about to learn and start practicing liver surgery. So the other thing is that all these segments I've just described exist in nearly every patient. There are some very rare, strange anatomic abnormalities, but you should understand that these are not just one branch going into every segment the way it looks on typical cartoons. There is extreme variation in proximal branching of both inflow and outflow vessels, and every case has to be individually examined, and there will be exceptions that change how you have to do an operation, and I'll show you some examples. So another thing to understand about the liver is, and I'm going to go into the extrahepatic anatomy, but understanding the segmental anatomy of the liver requires that you understand that at the hilus of the liver, the hepatic artery, portal vein, and biliary branches are nicely packaged in invaginated Glissen's capsule or visceral peritoneum, and then packaged inside the liver as a relatively rough structure that can be dissected around, is not that easily injured, and it runs as little pedicle branches. But I would want to point out that while these are nice, typical anatomy, there are all sorts of variation. As an example, you can actually see here, there's not a really long, common posterior sectoral pedicle. It's quite common that segments 6 and 7 come off very proximally without much of a posterior sectoral pedicle alone. I have seen variations where segment 2 and 3 come off as a single branch here and then branch inside the liver. We often talk about segment 4A and 4B. This, of course, is not true. There are typically multiple branches that go into segment 4. And if you're operating on segment 4, you have to sort of individually understand that. If you're also going to operate in the hilum of the liver, you have to understand this plate system. Most of you will be familiar with this because when you take out the gallbladder, you notice that while you've divided Glissen's capsule to start to remove the gallbladder off the liver, you are not looking inside the liver there. You're looking at a fibrous capsular type tissue that is called the cystic plate. And this extends into the hilar plate, which has to be understood and dissected for any kind of hilar surgery. It also then extends into the umbilical plate where the inflow vessels of the left liver run. Portal venous anatomy, very important, especially if you're doing the surgery on hilar cholangiocarcinoma, just like you heard. There is typically a left and right portal vein. The branches to the caudate were brought up just recently with a caudate branch from the left, a small caudate branch to the right. Very important as you control the right portal vein, whether you control it proximal or distal to this or take the caudate branch separately. In the transverse portion of the left portal vein, there are often little segment 4 branches there. But understanding the variation on the right side of this slide is important. Sometimes there isn't a common right portal vein, but rather immediate branching into anterior and posterior branches. This last variation is actually quite common and will be manifested inside the liver within the portal pedicles as well, where there is an early right posterior sectoral, then a sort of common channel, then an anterior sector, and then a left. You could describe this in a number of ways. Sometimes the right anterior is way over into the left side, and this is extremely important because this can be confusing and even resulting in taking the whole portal inflow if you don't get this right. And this requires looking at the scans very carefully. I'm not going to go into hepatic artery anatomy except to point out that there's always very common variation. You can see the typical common hepatic artery giving off the gastroduodenal artery, the proper hepatic artery branching into right and left branches. It's a really important relationship here that I think the young surgeons don't always appreciate, that the right hepatic artery runs posterior to the common hepatic duct. About 10% of the time it runs anteriorly. There's also issues where the segment 4 branch typically comes off the left, but can come off the right hepatic artery. And of course, anybody has to understand the accessory and replaced vessels either coming off the SMA or the left gastric artery. There's lots of variation, and if you're going to be operating in the hilum of the liver, looking at a good triphasic or multiphasic scan, you should know this anatomy before entering any liver operation. Most of you know the biliary apparatus. You just heard a little bit about this. Typically a right and left duct joining as one, common hepatic duct and the cystic duct joining a more inferiorly to form the common bile duct, heading into the behind and into the head of the pancreas. But this is the most important thing to understand, especially if you're doing lobar type resections or operations like hilar cholangiocarcinoma. On the right side of the slide, you can see that there are all sorts of strange branching that don't really make any sense and are highly individualized, but probably the most important thing to understand is that it is relatively common that a sectoral duct, most commonly the posterior sectoral duct from the right side, can drain into the left hepatic duct. And this can happen quite well over to the left side. So if you are doing a left hepatic lobectomy or a left hemihepatectomy, you have to be quite aware that it is very easy to injure a sectoral duct if you are not careful with the biliary dissection on the left side. I have seen this. I've seen left hepatectomies done, and then chronic dilatation of the posterior sectoral bile duct to the right liver with a chronically elevated alkaline phosphatase. And that's from a narrowing right here for someone who did not appreciate this anatomy. You can see this on good quality CAT scans. You can see it on MRCPs. Historically, some people used to do MRCPs on every left-sided resection to define this anatomy, or it obviously can be worked out at the time of surgery as well. Understanding the veins are important because these are where the main planes inside the liver exist. I also put a little asterisk because the veins are where all the bleeding comes from. Whenever you're dissecting through the liver and you start to see a little bit more blood than you think you should be seeing, you're approaching a major vein every single time. You can see that the middle of the vein drains the anterior sector, the right vein drains the posterior sector. Of course, there's variation to this. I think you should also be aware of a vein that we typically refer to as the umbilical vein. It can come off the left or come off the middle, running in the umbilical fissure here. But again, there are very significant branching patterns. For example, the left and middle veins typically come together as one before entering the cava, but sometimes come off separately. There are often inferior right hepatic vein branches, and I'll show you an example of that in a minute, that vein the lower segments of the right liver. So this may be confusing if you don't do a lot of liver surgery. Hopefully I've illustrated that understanding this level of detail is important. You can't learn it in 20 minutes. It requires a lot of study. But why is it important? I think it's important to understand why you should study this. And I'll tell you, in my experience, having operated in the liver for about 20 years, there are two things a surgeon can do to minimize morbidity after liver surgery. Probably the most important one is to resect less liver. Every tumor sitting in the right lobe of the liver does not require a right hepatectomy. And in fact, if you're able to take out a segment, it's well worth the extra work to do this because the morbidity plummets when you take out less liver. And the only way you can do that effectively is understanding the segmental anatomy of the liver. And of course, not losing a lot of blood is quite as important as well. And that really requires, again, understanding the anatomy and planes inside the liver to do it effectively. Now, I've on purpose showed this very old data set to illustrate what has been shown time and time again since this time. But as you take out more liver, these are the number of hepatic segments removed. You can see, now these numbers have gone down over the years, but they're in parallel currently. The morbidity goes up, the mortality goes up, and you can see that an extended liver resection, taking out multiple segments. Now we've done better with portal vein embolization, but the mortality is going to go high, but you can see the major complication rate and the mortality is extremely low. And when you start taking out 4 and 5 segments, there is a significant risk of liver failure, and that can be lethal. You take out 3 or less segments, liver failure simply does not occur. It is exceedingly rare unless you are doing liver surgery on a bad cirrhotic. So in my mind, taking out segments rather than whole lobes or hemilivers, a critical part of being a liver surgeon. And I bring up this picture and some common segmental resections. And I think if you have something in the posterior sector, taking out 6 and 7 rather than the whole right lobe of the liver is by far the preferred approach, because again, taking out 2 segments, the risk is low. There's no liver failure. They just recover from the resection. But any number one of these, any single segment should be able to be resected. Any sector should be able to be resected. There are complex central operations like 4, 5, and 8. Even uncommon operations like segments 5 and 6, Of course, the common left lateral segment of segments 2 and 3, relatively straightforward, or 4B and 5 for, like, say, a gallbladder tumor. These are the ways you should be operating on the liver. So here's some examples. Maybe a little hard to see, but this is the vena cava. You can see a vascular loop around the right hepatic vein, and then you can see the segment 7 pedicle. And this is the kind of single segment operation, which is not easy to do. But if you do this, the patient will not suffer any major physiologic insult from this operation. And it's well worth doing. Here's an example, perhaps an extreme example, but one that I think illustrates how you can take out single segments. Here's a tumor straddling segment 7-8. You can see this is the right hepatic vein. And I would bet a lot of money that most liver surgeons would take out the right lobe for this. But this patient had a really interesting anatomic variation with a large inferior right hepatic vein draining segments 5 and 6. And so what you realize when you do this is you can take out the right hepatic vein, segment 7 and 8, and you will not compromise venous drainage. And this is the kind of thinking. Now, people might find this not worth it, but in my mind it is. And so in an operation like this, ignore the diaphragm resection, but you can see the right hepatic vein's been divided. You can see the accessory right hepatic vein in place, and it's a little hard to tell, but there's a large resection of segments 7 and 8 having taken the right hepatic vein, and segments 6 and 5 are well drained. 2 segments, no risk of liver failure, and this patient will recover simply from the laparotomy rather than the risk of a physiologic huge insult from taking out a big piece of liver. We don't have time to go into this, but of course you have to know the extended and lobar type resections from both the left and right side. And I think these are commonly taught principles, but I think the challenge is the segmental resections. A brief comment about minimizing blood loss. There was a comment from Ajit about lowering the CVP if they are dehydrated to begin with. Of course, you have to be very careful. We routinely keep the CVP low. You can really tell what the CVP is by looking at the vena cava and knowing immediately. If it's bulging and full, you're probably going to lose some blood as you get near the veins. I don't use a lot of Pringle anymore, but that's after many years of doing surgery. But I think when you get started, you should Pringle routinely until you get comfortable doing surgery without Pringle. Many trials show no harm to Pringle maneuver. You have to figure out a way to divide liver tissue safely so that you can see intrahepatic anatomy. Transection is not a frantic effort to coagulate things. It should be a dissection with demonstration of anatomy. And as you start to do more liver surgery, those segmental pictures I showed you, there are planes actually around these, and you can start to appreciate them the more you do. I will tell you, liver surgery is not about fancy instruments. They're fun. They can be a little helpful. But the person who taught me surgery on the liver was Leslie Bloomgart, and he did it with a low CVP, a Kelly clamp, which I still use, clips, and maybe a stapler for some major vessels. It is not essential to have fancy instrumentation to do good and effective liver surgery. One last comment about the wedge resection. The wedge resection is often sort of seen as a sort of bad technique or non-anatomic resection. And I think this is a poor description of what this kind of resection should be. A well thought out wedge resection, which I do all the time, based on the anatomy, the subsegmental anatomy of where you're taking out the tumor. It can be a very effective surgery, especially if you're doing contralateral major surgery. In my opinion, if you do it right, it's not non-anatomic at all. It's taking small peripheral branches, which are carefully planned out. As long as you're not compromising margins and you're reviewing the specific peripheral anatomy, it can be a very effective thing to do. A poorly defined wedge resection, leaving a bunch of ischemic liver behind, having taken some major vessels, is obviously a terrible idea. So it has to be well planned. So that's my 20-minute description of liver anatomy, which I'm smiling because, of course, to truly teach liver anatomy takes a long time. But knowledge of anatomy is critical. I know that sounds obvious, but in the liver, it's not the right lobe and the left lobe anymore. Never, it hasn't been for decades. It's understanding all those segments, but also understanding that every patient has their own anatomy with individualized anatomic branching and variations on the theme. Don't get caught up in the terminology. We do have the segment numbers that are universal language, and if you're unclear to what to say, use the numbers. And when you're doing surgery, I can't say it enough, when you can take out less liver, you will start to see that these patients don't suffer much at all. Obviously develop techniques to lose little blood. And that's it. I'll end there, and I'm happy to take any questions.
Yes, hello, great. Good day. Hi again. Are there any questions for Dr. Mike before we move on? Dr. Mike, fantastic talk. Thank you so much. You did so much with the little bit of time we gave to you. Very much appreciated. Just in the interest of time, I think we'll move on, and I'll ask anyone with questions. So please just do so on the chat, and we could always have Dr. Mike, apologies, Dr. DeAngelica, address them later on. Thank you so much. Okay, so moving on to our next speaker. I think based on the first two presentations so far, I think we could definitely agree that the reliance of modern day surgery on radiological imaging is undeniable. This can be no better demonstrated by the sacred bond that is shared between a hepatobiliary surgeon and the radiology consultant. That being said, I'm delighted to introduce you to Dr. Tanzila Barrow. Dr. Barrow is a graduate of the University of Oxford and completed her postgraduate radiology training in Manchester. She is currently a consultant radiologist at Manchester Foundation Trust at Manchester and the Eric Williams Medical Sciences Complex right here in Trinidad and Tobago, West Indies. The areas of subspecialty interest include hepatopancreaticobiliary and gynecological malignancies, as well as oncological PET-CT. Thank you, Dr. Barrow, for gracing us today with your presentation on the overview of diagnostic imaging in hepatobiliary surgery.
Thank you, Dr. Ara. Can you guys see my screen?
Yeah, we're seeing you and hearing you well.
Perfect. So I'm going to give a brief overview on the imaging approach to HPB lesions. Hang on. Okay, perfect. So radiology, as we've heard, plays a key role in both the diagnosis and guiding the management of patients with HPB lesions. So in this short talk, we're going to talk about the different imaging modalities at our disposal and how we can use them through a series of case reports. Now, this is by no means an introduction into the kind of complex staging and looking at vascular encasement, etc. in patients. It's more choosing the right modality. Okay, so what do we have in our radiology toolbox? We have ultrasound, CT, MR, nuclear medicine, and biopsy. And we're going to look at the top four today. So ultrasound is often our initial investigation. For example, here, a patient with right upper quadrant pain with cholelithiasis. Those presenting with jaundice sometimes. This is an example of a patient with bilobar intrahepatic biliary ductal dilatation. And you can see there's an abrupt cutoff of the left and right intrahepatic duct. There's an isoechoic mass representative of an intrahepatic mass-forming cholangiocarcinoma. Not uncommonly done for deranged LFTs. Here's an example of hepatosteatosis. And then with those come the incidental liver lesions, benign ones, most commonly cysts or hemangiomas. And the second subcategory is those that we are using ultrasound for surveillance. So this is an example of a patient with a gallbladder polyp. We're looking, surveilling the size of the polyp, but also looking for malignant features, a different patient showing hypervascularity within a large gallbladder lesion. And then those with diffuse liver disease, looking at not only the cirrhosis, the fibrotic RFE scores of the patients, signs of splenomegaly, portal vein patency, direction of portal vein flow, and surveilling for early detection of focal liver lesions in this patient population. Unfortunately, ultrasound is limited by the presence of fat. This is the same lesion on a different background liver. The image here shows a normal background liver and there's a hypoechoic mass. Same lesion in a fatty liver is shown as hyperechoic. These are hepatic adenomas just on a background different liver. So really, we then need something else. And as my colleagues have talked about, CT is really the mainstay of staging patients. It allows us not only excellent spatial resolution, it lets us look at the arterial anatomy, lets us assess the lesional enhancement pattern as well. So, for example, here we've got a patient with established hepatic cirrhosis. There's a large liver lesion showing hypervascular enhancement on the arterial phase, followed by portovenous washout in keeping with a HCC. And then we have MRI, and really MR is used for multiparametric assessment. It allows us to assess the anatomy, enhancement pattern, morphology of the background liver, as well as that of the lesion. I'm going to take a few minutes just to talk about what MR to request, because I find that this is a point of contention sometimes locally. So I split it into three. We have MRCP, done really for ductal anatomy, stone disease. We have MR pancreas, which includes an MRCP sequence, but also includes pancreatic phase post-contrast imaging. And then we have the MR liver category. So at MRCP, like I said, normally for stones, sometimes for strictures, congenital anomalies, and post-surgical anatomy. This is an example of a patient who's undergone a previous liver transplant and has developed a common hepatic duct stricture. Next, we have the category of MR pancreas. So most commonly, it's done for cysts, incidental cysts picked up on other imaging and for follow-up. And it's looking really at the morphology of the cyst and any kind of adverse features. On this example, there's some subtle soft tissue at the posterior aspect of the cyst, which post-contrast shows mural nodularity. This is a proven malignancy. There is some controversy as to what you should do with those sub-centimeter side branch IPMNs that we all find incidentally and then end up following forever. Historically, we've tended to do an MRCP and alternate with an MR pancreas, but actually the more recent data suggests that all those patients should have an annual MR pancreas because of the risk of developing an adenocarcinoma, not just within the cyst itself, but also elsewhere within the pancreas. And then we use it for the kind of solid lesions or suspected neuroendocrine tumors. This is an example of a patient with a prominent pancreatic duct, abrupt cutoff in the proximal body, suspicion of an ISO attenuating mass or perhaps a pancreatic duct stricture from previous pancreatitis. And the MR pancreas clearly shows there's a focal lesion within the pancreas at the point of duct transition. And this was a proven adenocarcinoma. And as Prof. Sorodina talked about, we also use it in kind of pre-surgical planning for patients with suspected cholangiocarcinomas and also in patients with chronic pancreatitis. We move on to kind of MR livers. And the majority of MR liver work is with Gadavist, which is a renally excreted post-contrast agent used for diffuse liver disease, the detection and characterization of focal liver lesions, tumor response, and congenital anomalies such as Abernathy's. And then we have the second category, which is Primavist. Primavist is a biliary excreted agent. It allows for a hepatocyte-specific phase at about 20 minutes. So it shows you lesions that take up or do not take up Primavist and therefore suggests kind of functional Kupffer site presence. Because it's biliary excreted, it can also be used to look at bile leaks. Okay. The only other thing to note is that Gadavist offers better kind of arterial and portovenous phase imaging, much truer than a Primavist phase. So we tend to use this as a main workhorse. And then we have the non-contrast category, which is really kind of up and coming. So the Serenade trial is a multicentric phase 2 trial in the UK, which looks at patients with colorectal cancer with poor prognostic factors such as EMVI, T3 disease, or nodal disease. And it's looking at whether, if you perform a diffusion-weighted imaging at baseline, whether you pick up more occult mets that you haven't seen on the CT. The results aren't in, but people have started, multiple centers have started now incorporating this because the results are very promising. Okay, so just to kind of show you kind of Primavist, this is an example where it's been used. Patient, young female, has got 2 liver lesions, one here high in the left lobe and one here in segment 7, both arterially enhancing. The one anteriorly shows on the hepatocyte specific phase at 20 minutes, normal Kupffer cell uptake. It's ISO attenuating to background. This is an FNH. This lesion at the back is seen as a black hole. It contains no functioning Kupffer cells. It was in keeping with an adenoma. So often we will do a Gadavist first, and then on follow-up, we will consider doing a Primavist scan. This is a lesion. This is a patient with colorectal cancer metastasis. We would do a Primavist pre-surgery in these patients because it makes the metastasis easier to find, make sure we're not missing any lesions prior to surgery. You can see here on the heavy T2, there's a small sub-centimeter, mildly hyper intense signal in segment 6, much better appreciated on the Primavis scan. And just using that fact that Primavis is biliary excreted is an example of a patient who's undergone a right hepatectomy. Clinically, there's concern of a bile leak. Patient undergoes an MR liver with Primavis, which clearly demonstrates there is leakage along the resected liver, which is demonstrated again on the subsequently performed ERCP and stent. We also use MRs for kind of problem solving. Here's a patient, 53-year-old female, previously undergone a left lateral sectionectomy for colorectal cancer liver mets. This is the baseline image, incidental lesion here. You can see the right side is clear. 6 months later, patient comes for a follow-up and there's a hypo-attenuating lesion, best seen here on the liver windows. So we do an MR to further characterize the lesion. Here's the lesion here on the baseline CT. We have the in-phase and out-phase T1. You can see that the lesion is iso-intense to the background of T1 and shows significant dropout in keeping with lesional fat. There's no post-contrast enhancement and no restricted diffusion. This is in keeping with focal fat rather than a new metastasis. Conversely, we have a patient here, 48-year-old with FAP. He's currently undergoing chemotherapy for colorectal synchronous malignancies. Baseline imaging shows no focal liver lesions. At 5 months, there's a sub-centimeter lesion in segment 6, again shown better on the liver window. Patient undergoes an MR. MR confirms the presence of the segment 6 met, but also finds 2 further sub-centimeter liver lesions. So really, you know, MR for looking for those occult mets that you may be missing on the CT. And then we talk about nuclear medicine and molecular imaging, combining functional information with anatomical location. And perhaps the most historical of which is the Octreotide scan, looking for neuroendocrine tumors, and recently replaced by PET-CT. 18-FDG is the most commonly used agent or tracer when we do PET-CT, but there's multiple new tracers on the market. And the one that we tend to use for HPB is the gallium-68 DOTATEC, which is another somatostatin receptor imaging. So let's just talk about non-neuroendocrine imaging first. So 18-FDG PET-CT is the main workhorse for PET. It's commonly and routinely used for oligometastatic colorectal cancer metastases, where you want to go and take out the hepatic mets, but want to make sure you haven't missed another site of disease that's extrahepatic, and also used in patients where they might have oligometastatic breast tumor, for example, to liver. And as Prof talked about, there is a potential considered use for those with potentially resectable cholangiocarcinoma, high-risk borderline pancreatic primaries, and HCC where there's suspicion of metastatic disease or an equivocal finding on the CT that's been performed. So here's an example. Here's a patient with colorectal cancer metastases. We know they've got a liver metastasis. The CT demonstrates a sub-centimeter lesion within the proximal pancreatic body, and 18-FDG avidity shows that that is actually a metastasis in the pancreas. The patient does not undergo liver resection. And then here's another example, another patient with colorectal cancer metastasis. On the baseline CT imaging, there was this small lesion in the upper pole of the spleen. Wasn't concerning on the performed MR. Patient undergoes an 18-FDG PET at baseline, which demonstrates no avidity. Follow-up imaging demonstrates that this lesion has increased. It was indeed a MET, it was just too small to see on the background uptake. So just have to bear in mind that 18-FDG is very useful for extrahepatic disease. Can't use it to assess the actual disease burden within the liver, and be mindful of the spleen because there is normal physiological uptake which may be obscuring lesions. And sometimes, unfortunately, it does come back to time. Here's an example of a patient with known HCC. This is patient underwent 18 FDG PET. You can see on the CT component of the PET, there's a large lesion here. 18 FDG demonstrates no uptake. Same patient undergone what's currently being investigated for HCC. This is a gallium PSMA scan, and interestingly shows marked increase. So there are new traces and which show promise for lesions such as HCC, and it's really an area to watch. And then an area of interest, neuroendocrine imaging. So historically, we talked about octreotide imaging, and that's really been replaced now by gallium-68 PET-CT. So here's an example. This is a patient with a known pancreatic neuroendocrine tumor. The primary tumor is completely obscured by normal physiological uptake within the spleen and liver. It does demonstrate a solitary site of metastatic disease in the left supraclavicular fossa. Same patient undergoes a gallium dototec PET-CT 4 days later, and you can clearly see there is multiple sites of nodal and bony disease. Gallium dototec 68 has a 96% sensitivity for neuroendocrine disease, unlike octreotide, which has a 72% sensitivity. This is relating to the fact that the gallium dototec has 100 times more affinity for the somatostatin type 2 receptor than the octreotide. In 2018, the Society of Nuclear Medicine and Molecular Imaging advised that octreotide be completely replaced in all instances with gallium-68, and this has been followed by the NCCN the same year. So when do we use gallium dototec? Well, we use it in the localization of both primaries and metastatic disease. This is an example of a patient with known metastatic neuroendocrine disease within the small bowel mesentery, but the primary disease is occult on the CTE performed. The patient undergoes a gallium dototec, and you can clearly see there's somatostatin receptor avidity in distal D3 representing the primary lesion. We can use it in the evaluation of disease response. Here, this is an example of a patient with rectal neuroendocrine tumor showing extensive metastatic somatostatin receptor disease within the liver, undergoes therapy, and then there's no residual somatostatin receptor activity within the liver, showing a disease response. And we can also use it to kind of determine what therapy a patient may benefit from. So here's an example of a patient with a large liver lesion outlined here in yellow on the CT. Patient undergoes a gallium dototec scan, which shows there's normal physiological uptake in the background liver. The lesion in question shows no uptake. Therefore, this area is void of somatostatin receptors, and the patient is unlikely to benefit from peptide radionuclide therapy. So is there a role for 18 FDG in patients with neuroendocrine tumor? And the answer is yes, but in some cases. And I think that's what's important to understand. Those with grade 1 or grade 2 tumors with a Ki-67 of less than 20% are unlikely to be FDG avid, but are more likely to be somatostatin receptor avid. Those with high-grade tumors with a Ki-67 of more than 20% are likely to be FDG avid and not somatostatin receptor avid. And that really results in the emerging role of dual tracer PET-CT for patients with lesions greater than 20 millimeters. Here's an example of a patient with metastatic grade 2 neuroendocrine tumor with mets to the liver and bone demonstrated on the gallium PET, but on the FDG, there's no avidity. Well, there's a discordance between the two. This shows that there's no abnormal glycolysis occurring within the liver and bone metastasis, and this infers a better prognosis for the patient. So let's move to an example. Here's an example in clinical practice, a case from Manchester. This is a gentleman with a large pancreatic neuroendocrine primary. Patient underwent a baseline somatostatin gallium scan at the time of baseline staging, shows marked uptake in the tumor and within a single nodal deposit. Patient subsequently underwent a splenectomy and distal pancreatectomy, had a slightly rough post-operative course, had a CT as an inpatient, which he developed this intrahepatic abscess, does well, is discharged. and on discharge is followed up with CT. CT subsequently performed 3 months later shows the intrahepatic presumed MET is reducing in size and no longer contains gas. And the plan at that point was to follow up the patient with an MR scan. Okay, we'll go back and we'll just have a look at the surgical clips. There's a little bit of soft tissue near the surgical clips, but nothing that would kind of worry you at this point. It'd be a site for review. So the patient undergoes an MR. The MR shows that this lesion here, again, has gotten smaller, is cystic, and shows no restricted diffusion. It's in keeping with a resolving intrahepatic abscess. However, it does pick up 2 hypervascular metastases within segment 7 of the liver, which show restricted diffusion. So again, the patient has a gallium Dototec 68 scan. I keep this image here just to show you the normal physiological uptake on the gallium scan within the liver. So these lesions cannot be seen. We cannot assess the liver here. Interestingly, though, the area of increased soft tissue at the surgical clips, which were a site for review, which demonstrated no associated restricted diffusion, do show somatostatin receptor positivity, indicating residual disease at the pancreatic resection site. So very helpful. So in conclusion, we stage all patients with a multi-phase CT. However, MR allows superior lesional characterization, provided you choose the MR protocol wisely. PET-CT is a useful adjunct, and new PET traces show significant promise. Thank you. I'll take any questions if anyone has any.
Thank you very much, Dr. Barrow. Again, yet another fantastic talk from our panelists. Unfortunately, I know the program did say that there would be a coffee break now, but in the interest of time, we're running a little bit over time, and we want to be considerate to our colleagues out there who may be present in different time zones. Even though it is quite a sunny, clear day here in the Caribbean Sunday morning, we know this may not be the situation everywhere. So I'll invite you all to probably, if you do want, you could grab a cup of coffee while we continue with the rest of the presentations, if that's okay. Dr. Barrow, and as well as all the other speakers, I actually have quite a lot of questions I wouldn't have mind asking. That's the downside of the virtual setup, that this is, usually during the coffee break or afterwards over drinks, I could always approach you and ask questions. Maybe next time. Okay, but again, I will invite anyone who has any questions to put them on the chat, and we'll try to address them hopefully before the end of the program. All right. Thanks very much. So one final call. Any questions to Dr. Barrow before we move on? Okay, we do have a question, Dr. Barrow, on the chat. I don't know if you're able to see.
Yeah, so the question is, can radiological modalities help surgeons delineate potential vascular anomalies they will find at surgery? And the answer is absolutely. A good CT in the right phases is really the roadmap for our surgical colleagues. And that's what the MDT is there for, to go through any variant anatomy that we can see. It was just unfortunately beyond the scope of a 20-minute talk.
Yes. Okay, good. So moving on now, we have Dr. Chad Ball. He will be delivering a talk today to us on the variety of operative techniques for dissection of liver parenchyma. Dr. Chad Ball is an associate professor of surgery and oncology at the University of Calgary. He currently practices hepatobiliary, pancreas, trauma, and acute care surgery at the Foothills Medical Center, which is a quaternary care regional referral facility, and is the director for both the HPB and acute care surgery fellowship programs. He completed his undergraduate degree at the University of Alberta. He has a graduate degree from the University of British Columbia, attended medical school at the University of Toronto, and completed his general surgery residency at the University of Calgary. He then went on to pursue a trauma and surgical critical care fellowships at Emory University and a HPB fellowship at Indiana University. He has over 250 peer-reviewed publications, 35 book chapters, and is an international speaker on a broad range of surgical and resuscitation topics. He's on a broad range of surgical society executive committees, as well as peer-reviewed journal editorial boards. please welcome Dr. Chadball, who will deliver his talk. Thank you.
Thank you so much. It's such a pleasure to be here. Try and share my screen. Thank you from the entire Canadian HPB Association.
Sorry, Dr. Ball. I don't know. I think there may be some issues with the audio. Is everyone hearing Dr. Ball?
Yeah, we can hear.
Can you hear
Oh, you
me?
hear him? Okay, good, great.
Perfect. I'm just going to share my screen here. Can you guys see that? Wonderful.
Yeah, hearing you and seeing clearly now. Thanks.
Perfect. Well, I just want to thank you for the invitation on behalf of the Canadian HPB Association. Our affiliation with the Caribbean group and you folks in particular goes back a long way. I can remember almost 10 years ago sitting in a room with Mike D'Angelica, sitting beside Wesley Francis, trying to craft and carve the Caribbean a chapter into the HPBA, and that was a fun experience. We've also, I think, really had the benefit, particularly in Calgary, of some really wonderful trainees over time, starting with Wes, then Don Major, and now the absolute superstar Greg Padmore, who will be coming back to you shortly. We're going to miss Greg as we miss Don and Wes and others as well. So thank you. I just wanted to echo, I think probably I got the easiest talk of the entire day here. There's not much science to present. It's a lot of opinion. And we just did this topic recently at the last HPBA meeting. And there was certainly lots of opinion and lots of fun. So hopefully it'll generate some thoughts and some comments. I would also agree both with Prof as well as with Mike D'Angelica that, really the evolutionary jump in liver surgery over the 15 years I've been doing it, the 20 years Mike has been doing it, even longer that Prof has been doing it, comes from, I think, three things. And the other talks leading into this have really hit the nail on the head in terms of a 30,000-foot view. The first thing is our understanding of anatomy. And that's not only the radiologic preoperative preparation side of it, but also the intraoperative ultrasound component of it. And of course, the experience side of it. Low CVP surgery was mentioned, and that obviously has revolutionized liver surgery. And I would certainly agree with Mike that, a lot of us can certainly do these procedures, these resections with any instrument you hand us. But there is certain instrumentation, certain energy instrumentation, certain technique that certainly makes those resections easier in any given patient. So let's move forward. We could start way back, talk about the ego eating Prometheus's liver as the first maybe non-energy or maybe in fact energy instrument for a liver resection, but we'll move forward from there and take a quick stop here at the Kelly technique. Dr. D'Angelica mentioned this. It's still a tried and true technique. Obviously, the concept is an educated insertion of an instrument such as a Kelly clamp into the liver parenchyma, very gently without overly using too much force, and then closing it and opening it very gently, with the idea being that your bile ducts and your vessels will then be left for you to clip, cut, or move through with energy. There's no question that even those of us who like maybe more modern or contemporary energy instrumentation devices still use a Kelly count procedure, a technique in some elements of almost every liver resection. And again, as Mike pointed out, you can do really almost all liver resections using this technique. You can see in the picture on the right there, as I mentioned, they've decided to use a combination of an energy instrument with a Kelly clamp. And certainly, I think, globally, there's two dominant energy instruments that we use for bread and butter of all things under the umbrella of general surgery. Without mentioning any proprietary names, this is obviously the first. This is the ligature, and it comes in different hand pieces, as we know. There's a Maryland fine tip. There's an impact, which is the instrument at the top left here. And then there's smaller instrumentation as well. And I think which of those you choose depends a little bit on, your margin status, where you need to go, the finesse, and of course, what you're comfortable with. The generators that run this particular energy instrument are really quite widespread. There's multiple companies that make these generators. You don't have to use the fanciest, most recent Value one, for example, at the bottom here. But really, you find these all throughout a large portion of the world. And as somebody who's operated on every continent on the globe, there's almost always an energy generator that will run this particular instrument. So it can be very helpful. It can be used sort of alone or in conjunction with a Kelly clamp technique. Of course, a lot of us also use the harmonic energy device from a separate company. Although the generator in the bottom left looks pretty, it's a little bit harder to find on a global scale. There's open instrumentation and laparoscopic instrumentation. I think a lot of us who do a lot of laparoscopic livers will tend to use this device for the laparoscopic approach or methodology. There's been multiple iterations of this instrument over time, but obviously each instrument has its own pros and its own cons. One of the limitations or one of the challenges with this instrument is the tip of it. And you can see there's the black part of the forceps and then the white part of the forceps. And that white, as a lot of us know, represents a Teflon coating. So if you use this instrument, for example, like a ligature, in terms of how you move through the liver and how you close it, you will very quickly burn off that Teflon white coating and need a new instrument entirely, which of course you want to avoid. So closing this particular instrument very slowly, very cautiously, very carefully, and once it's closed, hearing that click and then releasing quite quickly will let you use this instrument through even, for example, a right posterior sectionectomy with a lot of liver parenchyma to go through, but really quite a nice instrument. This is also an interesting tool. It's something that we used for quite a period of time. And to be fair, I'm not going to talk about anything that I haven't used a fair bit personally. I don't think that's exactly fair, but this is called the AHPBA, and this is the second iteration of it. It's an interesting instrument because it's got two different things going on. The first is that it's a hydrodissection unit. So it pushes out very high velocity streams of water that essentially blow away the hepatic parenchyma in and around blood vessels and bile ducts. It also, in the most recent iteration, can apply straight monopolar electrosurgical current. And so you can see that there's sort of three parts to hooking up the handpiece, but at the end of the day, it's just a single button on the handpiece and is quite simple. It works quite well. It comes with its own specific generator that is specific to the instrument, so it means an extra cost there. And you can see the picture on the right is the water jet itself blowing that away. This is only one of two industry slides that I will show you. You can obviously set what they call the effect intensity, greater or lesser, and that really equates to the depth of the penetration. You can see on the far right tile, the fourth picture there, they've activated the monopolar cautery, which helps you burn through some of those smaller bile ducts and vessels more rapidly. There's an instrument called a HPB. I don't know in the Caribbean if this is well used or not. Again, we used it for a little bit in certain resections, and it certainly has a number of limitations, and it's very regional in terms of its uptake. You can see that it has, in this particular example, two prongs that extend into the liver, and the gold part at the bottom has a bit of a safety catch that you set in terms of depth. You then insert that into the liver itself, and in general create two resection lines. Once those burns have been completed, you can really cut through the liver with anything that you want, including a scalpel, as shown in this picture. Now you can imagine there's significant geometry and morphology limitations with this instrument. You can also poke that instrument into things that you really don't want to poke and certainly ablate or destroy. I would also echo, Mike's comments about this particular industry figure, and I don't know exactly what the collective listening would do, but I certainly wouldn't do a large right hepatectomy for this lesion either. This would be a relatively small segmental wedge resection, at least in our center. So really this instrument, I think, in my opinion, has come and gone and not been overly helpful. I'd like to spend a little bit of extra time then talking about the aquamantis. I know this has recently come to the Caribbean, and my hope is that Dr. Padmore can help propagate it through the Caribbean if you find it to be helpful. I certainly have no association with this company at all, so hopefully you'll take my comments at face value. The company that now owns the Aquamantis energy device uses the term transcollation. I don't know if that's a made up term from them or if it comes from somewhere else, but really it's a dual energy technology. So the first is that it's bipolar radio frequency energy. And the second is that it uses saline and actually boils the tissue. And I like to take the risk, if you'll be patient with me, to try and show you some videos, and I'll flip back and forth on this laptop, as I think, trying to show videos embedded in this format's a little bit difficult. But at the end of the day, the concept is the same. You're trying to ablate or energize vessels and bile ducts and hepatic parenchyma to be able to come through it with a second instrument. So the handpiece of the Aquamantis energy device is also very simple. You can see there's a single blue button on it. And there's a number of different styles of handpieces. So they call this, again, I don't know why, a 9.5 XL. And you can see that the tip of this instrument has two sharp points with a hole on each side. The hole is where the 0.9% saline bubbles out or flows out, which is then ignited or boiled by the energy created with the bipolar tip there. The instrument, when it first came out, was a rounded tip, and I'll show you that in a second. But the benefit of the pointed tip, as you'd imagine, is it's much simpler, much easier to move through the liver in a bit more of a dissectionary way. Particularly that would be the case for not only cirrhotics and hard livers, but also sometimes fatty livers as well. And for those of us who operate more and more on large fatty livers, you'll feel that pain. The older tip is called a 6.0, and you can see it's a similar setup, except that it's a rounded tip. And Dr. Patmore asked me to talk a little bit about the work we've done in moving this into the trauma space and the general surgical space and even the thoracic surgical space. But that would be the instrument that we would recommend, the tip that we would recommend for those domains, those fields, the 6.0, the less pointy one. There's also a laparoscopic version of the Aquamantis, and again, just my personal opinion. Our group here doesn't like it. It's never had the uptake, I think, that the open technology has been kind enough to offer. So again, most of us will use a harmonic or a ligature laparoscopically. This is the energy generating unit, the original one, and I'll show you the more modern one shortly in a video. You can see there's really only two settings. There's a power setting, which is the bipolar component, and there's a flow rate for the actual dripping of the saline. For liver resections, we tend to use this at 120 and low flow, although we will modify that depending on the context of the specific liver. So again, cirrhotics a little bit higher on the power setting, a little bit higher on the flow rate, and fatty livers, for example, the opposite. I put this picture up to remind myself to tell a story whenever I talk about this instrumentation, and I think the HPBA most recent meeting, they were laughing pretty hard at this story. But I've been using this instrument for about 15 years, and I remember in the first year of using it, we were coming through a liver and it just wasn't working. There's a distinct sound and snap and crackle and pop to this instrument when it's working well, and it was just not working well. It was tons of bleeding. It was uncomfortable. And the nursing, circulating individual asked if we could stop using the instrument for a second because they had to change over the bag of fluid. So of course we did that, and she asked if we wanted to continue on with D5W dextrose or if we wanted to switch to saline. And at that point, it was a very, very important lesson that obviously you need 0.9% saline, you need sodium chloride to conduct that current and boil that fluid. So that's something that we always check before we start every case. I'm going to try and pull out here a little bit and open up a video here. Let's see here. Thank you for your patience. I hope that everyone can see that. Yep. Okay, Perfect. I turned off the volume here. You can see the instrument is very, very simple, and it's not unlike the ErbiJet, the CUSA, a lot of other instrumentation for sure. There's a suction device. This is Greg Padmore coming through the liver here. A suction device on the left. We have regular Metzenbaum scissors. We have a multi-clip applier, and then the energy instrument as well. The advantage of that sharp tip, as you can see, is it really does able to allow you to dissect in and around bile ducts, in and around small vessels. And you can even come down the side of hepatic veins, for example, if you're trying to find the middle hepatic vein and use that as your resection margin. It does those little branches quite nicely. You can also see on the left side that there's a Rommel tourniquet that is not engaged, but is positioned. And I particularly like what Mike said, his comment about, portal inflow occlusion. The truth is that when we look at our resections in the past 12 years, we use it less than 1% of the time. And I would take us back to my initial comment about why that is. It's a better understanding of liver anatomy. It's a low CVP environment. And then really, quite honestly, it's also the addition of some of these modern energy instruments that just simply lose less blood, allow us to do more nuanced, more granular, and more detailed resections. So quite simple. I will point out that the person with the suction on the right side of the screen here, your goal is not to suck all that boiling saline away, because of course that's superb for hemostasis. But of course, you want to be able to see what you're cutting as well. So there's a bit of a dance. And I would also argue that this technique with two people who know how to use it well certainly does move the procedure and the resection along very quickly. I'm just going to move over to a second video here for just 1 second, and we'll share that. Obviously the resection here has been completed, and now we're sealing the large edge of the hepatic parenchyma of the liver remnant. There's a few different ways to do this, but one of the things you're particularly looking for, again, is that snap, crackle, pop sound at the space you're in. So you don't paint the liver like a traditional argon beamer or high voltage electrocautery. You want to push hard into the liver, give it that.
That video isn't shared, sorry.
Oh, sorry, guys. Okay, let's see if we can do this again. All right. It's funny how that does that, hey? Can you see that video, Greg?
Yeah, that one is on.
Okay. Still see it okay? So yeah, I was just commenting on the sealing technique of this particular energy instrument. Really, the reason you do this has nothing to do with hemostasis. There's no Pringle clamp on this patient. You can see it's not bleeding. It's not going to bleed in the future if you just stopped, independent of topical hemostatic applications, independent of anything. You're sealing this to prevent bile leaks. And certainly on an anecdotal basis, when you compare it to other energy instrumentation, the rate of postoperative bile leaks with this sealing technique seems to be a lot lower. And it's really one of the main advantages, I think, of this particular instrument. Okay, we'll stop that. I promise there's only one more video. Come back to talk here. Okay, hopefully everybody can see that. Back. One of the downsides to the instrument, though, and Greg will attest to this, that the tip of it can get quite charred, and those two little tiny holes that drip the saline intermittently do need to be cleaned, usually with a 22 or a 21 gauge needle. You just sort of grind out the material, and it tends to work quite well. But it does require some maintenance as you go. The other thing I promised Greg that I would just talk about briefly is some of the transitional work we've done, moving this into the trauma and general surgery as well as thoracic oncology space. As HPB surgeons, I know that everyone's on the list, on the line here, and wants to think about that particular domain. But The truth is that we all know we are called into general surgical rooms for hemorrhage control and injury control, not infrequently, in some places sort of on a weekly basis. We started to use this same Aquamantis energy device initially on patients, and then sort of went backwards, quite honestly. We went back to the lab and used it on a whole host of different pig tissues, and I'll show you some of that information, some of that data. It's kind of neat. And then pulled it into a multinational, multi-center prospective study in places like San Francisco General Hospital, for example, on trauma patients. And it's really been quite neat. You can see that if you look at that initial paper, the majority of the time, sort of 60% of the time, it was used during the initial laparotomy for a large hemorrhage to stop the bleeding. And then the other proportion of the time, it was for open abdomens and takebacks. Certainly surgeon reported information, so very qualitative, but it was successful in stopping ongoing hemorrhage the vast majority of the time. It was very easy to use, even for trauma and general surgeons who had never used this instrument before, and really performed quite well. To try and propagate that, we then published a video in a journal called Jovi, which you can find on PubMed. And it's a video-based journal of visual experimentation. It's quite interesting. And I just want to show you a couple of things in that video that are relevant to not only the liver, but also relevant to injury and other laparotomies. Now, can you guys see that video?
Yeah, we can see.
Perfect. So I'm going to skip ahead here. This is just probably a much higher fidelity and nicer video than the ones I showed you. But let me move forward here and show you. So we took the animal, the swine, and created a series of escalating injuries, predominantly in their liver, but also their spleen, their lungs, their retroperitoneum, their IVC, their heart, and their chest wall. As you can see, this is the newer energy box. It looks prettier, but it is of no different in terms of how it functions than the one I showed you. The tip, of course, is the same. So very easy to set up for a nurse in the middle of the night if needed. Extremely straightforward. So this is the animal here. You can see we're creating a whole variety of different injuries, all the way to complete transections of the liver. The other thing that was quite interesting was to try it on a number of different other tissues, as I mentioned. This is a simulation of a gunshot through the kidney. And although it's certainly not going to stop, a post-injury urine leak, you're going to have to deal with that. Just sticking that instrument through that bullet trajectory through the kidney stops the hemorrhage almost immediately. It's quite remarkable, quite honestly. The other thing that's interesting about this instrument is that you can run it up and down a number of large vascular structures. So you can apply it right across the inferior vena cava. You can do it on the portal vein, and you will not injure, perforate, or clot those vessels if the flow through them is normal. It's not surprising, probably, that, as you know, the flow through those structures, those large venous structures, is so tremendous. There's a massive heat sink. And so it really is nice in terms of cleanup in a more bloody or oozy case, so to speak. The last thing I want to show you on this video here is this slide here. So this is the depth of tissue penetration that we see when we apply that instrument to various types of tissues. And as you would guess, the more dense the actual tissue, for the most part, the deeper the penetration. And this is relevant for all of us doing hepatic oncology surgery, because there is a zone of ablation around this particular instrument. And you can see in a pig liver anyway, it was just under 3 millimeters in terms of depth of tissue penetration. The company will tell you that the energy created in terms of temperature is about 100 degrees. And that's in the vicinity of 100 to 200 degrees less than a typical ablation or other energy instrumentation. So it does allow you to dissect in and around those venous structures that are maybe tight. Maybe you're trying to take out an isolated colorectal met, between the right, hepatic vein and the middle hepatic venous trunk in a manner that you're trying to avoid a larger right hepatectomy, for example. So it is quite neat. I wouldn't recommend that you try this on a human heart. I'm worried about the electro component of arrhythmias in that scenario, but you can really use it on everything else. So that's all I wanted to show you in terms of videos. I hope that is what you wanted, and I'm happy to answer any questions at any point. Thank you so much.
Thank you so much, Dr. Ball. That was quite, I think Dr. Kawich did have a question. If we could get it. Dr. Kawich, you want to ask the question, or you would prefer if I read it off?
Sure. Thank you for a wonderful presentation, Dr. Ball. I was interested in your opinion on this. We recently found that using the aquamantis to transect the parenchyma led to a significant reduction in bleeding. And actually what it did was it saved us many staple fires to go across the parenchyma. But subjectively, I was wondering if we were seeing an increase in the amount of post-operative bile leaks. Now, our numbers are not sufficient that we can objectively say it's a statistical relationship. I was just wondering what your opinion was, and whether there were any tips or tricks that you could share with us in terms of the relationship between bile leaks and aquamantis use.
Oh, thank you for the question. Yeah, there's no question it's a powerful technology for exactly the reason that you pointed out. I will say that we are very hesitant to use the mantis across any bile duct that's major. And so that, for thinking back to Dr. D'Angelica's anatomical talk, we'll always come across the pedicles, the sheaths with a stapler. So we'll do the entire rest of that dissection and then staple those larger biliary structures, and certainly the large vascular structures such as hepatic veins and portal veins with for us, it's like a TX30 vascular stapler. I think that's part one. Part two, I think that the decrease in the bile leak rate that's traditionally been ascribed to that instrumentation, and that we've certainly noticed anecdotally over a long period of time, comes with the attention and care of the sealing at the end of the case. And to be fair, right, we do these intermittently really hard livers. We just want to walk out of the room, had enough. But it's that extra 20 minutes, 15 minutes of really sealing that liver. I think that does lead to the decrease in the bile leaks. And you really have to be fastidious about pressure pushing into that liver, listening to the sound, and then moving on when it's truly ablated to depth.
Thank you.
Okay, thanks again, Prof. Kawich, for your question. And obviously, thanks, Dr. Ball, for quite a fascinating presentation, especially the other utilities, extra utilities on trauma patients. I think that was quite interesting to see as well, or the potential use, I should say. So we would move on now. The time now, we're a little bit over time. But I would like to, it's my pleasure now to introduce Professor Avanish Saklani. Prof. Saklani. Dr. Saklani is a professor of colorectal and robotic surgery at Tata Memorial Center in Mumbai. He graduated in 1992 from KM Hospital, Mumbai. And after his surgical residency in 1996, he entered a surgical oncology residency program from 1996 to 2000 at Tata Memorial Center. He subsequently moved to the UK, where he acquired certificate of specialist registration in 2010 as a subspecialist in colorectal surgery. Shortly after completing a fellowship in laparoscopic colorectal surgery, he spent a year in as a robotic colorectal fellow at Yonsei University in Seoul, Korea. Dr. Saklani's field of special interest is laparoscopic robotic surgery for colorectal cancer, and he also runs a cytoreductive surgery and HIPEC program at Tata Memorial. He's extensively involved in training of fellows in laparoscopic and robotic colorectal surgery, and has published over 150 peer-reviewed articles and mentored surgical residents for presentations at national and international level. We are honored to have him today with us to give his talk on minimally invasive surgery for rectal cancer. Thanks.
Thanks, Amin. It's great to be here and good to see you again. And thank you, the Caribbean chapter. So I shall go on with my presentation. Can someone let me share the content? Okay, screen. Yeah. So my talk today is minimal invasive surgery in carcinoma rectum, I think. When you see someone with rectal cancer, I think you obviously do biopsy, do a colonoscopy to make sure there are no other synchronous lesions. We do a staging CT chest and abdomen and MRI pelvis. With early cancers are relatively less in the Indian continent, and most of them would be locally advanced. And they would require some sort of neoadjuvant therapy, either chemoradiation or TNT. And on response evaluation, if they have clinical complete response, that is no tumor seen clinically, endoscopically, or radiologically, they would go on wait and watch. If they've had good response, they go to TME. And poor responders, which are not uncommon, you can do extended TME or beyond TME excentrations. Lateral node dissections are done if on pre-op CTRT, the MRI, the lymph nodes were 7 mm, and after chemoradiation, if they still persist to 4 millimeters. I think evidence for MIS in colorectal cancer surgery has been there for a long time. You have the MRC Classic, the color, and the Korean. The recent trial at COSOG and Alakata showed some non-inferiority. When we look at long-term outcomes, the results were similar. So it's almost become a standard of care. But still, if you see over a period of time, the conversions or laparoscopy have been long. It was 34% in MRC Classic, which was the first one. And even in the recent ones, the conversion rates more than 10%. Robotic, on the other hand, so to have lower conversions, but so learning curve for laparoscopic rectal cancer surgery is a bit long. So to get better with time, it takes for less. The ROLA trial tried to compare robotic versus laparoscopy. The primary endpoint was conversion because most of the systematic review had shown conversion. In this randomized trial done by various surgeons, they found there was no difference in conversion between robotic to laparoscopic. It was 12% with laparoscopy and 8% for robotic. What they did find, there was an advantage in some difficult patients. If you are a male patient, obese patient, or you're doing a low anterior resection, the chances of conversions were less. So probably if you in a developing country, if you wanted robotic, you would select this group of patients. We would also select extended resections for robotic resections. The other thing, if you use robotic for abdominoperineal resection, sometimes you can see the quality of TME or the intersphincter dissection. You tend to go very low down. Sometimes your margins may be suboptimal. Surprisingly, despite good dissection with robot, the incidence of low anterior resection syndrome was not much different. Hopefully the video should start.
This is a video vignette demonstrating nerve-sparing low anterior rectal dissection for rectal cancer.
Anterior resection. This is a 29-year-old gentleman with middle third rectal cancer.
This is a video
and the tumor is 6
demonstrating
centimeters from the
nerve-sparing
anal
low
watch.
anterior rectal dissection for rectal cancer.
So young rectal cancers are not uncommon.
Our
For
patient
this
is a
nerve preservation
29-year
is
gentleman
important.
with a middle third rectal adenocarcinoma with moderate differentiation, 6 centimeters from the anal verge with a complete colonoscopy and no other
After
synchronous.
chemoradiation, he seems to have
The
good
baseline
response.
MRI showed a T3
The tumor is just above the
lesion
levator.
with no involvement of the mesorectal fascia. He received long course chemoradiation with capecitabine and 50.4 gray of radiotherapy. Response assessment scan showed a complete or a near complete response as seen here in the MRI images. The residual disease, if any, is supralevator completely without involvement of the sphincters. Hence, the patient was planned for a laparoscopic low anterior resection. Standard 5 laparoscopic ports as shown here were used. This video highlights the critical areas of nerve injury during the rectal surgery, especially during the IMA ligation, damage to the hypogastric nerves, during dissection, damage during the anterior rectal dissection, and damage during the posterior rectal mobilization. After adequate bowel positioning, dissection of the inferior mesenteric vein is started. Dissection in the correct plane is required to ensure preservation and safety of the retroperitoneal nerve structures. After dissection of the inferior mesenteric vein, now the dissection of inferior mesenteric artery is begun. Dissection begins from the region of the rectovesical fold just above the level of the ureter. Scoring just below the level of the inferior mesenteric artery helps us enter the correct plane. During this phase of dissection, all the care is taken to keep the hypogastric nerves down and to stay just below the level of the inferior mesenteric artery. Dissecting just outside the glistening envelope of the mesorectum helps us ensure safety of the hypogastric nerves. The presacral fascia contains the vascular and the neural plexus, and any breach of the fascia can lead to bleeding and injury to the nerves. Moving away from the initial retrorectal dissection, we approach the IMA root. This is the area where the pre-aortic superior hypogastric plexus converges to form two hypogastric nerves. Care is taken to stay just below the level of the inferior mesenteric artery and to drop all the nerves below. Any discrete lymph nodes in the pre-aortic region below the level of the inferior mesenteric artery are removed meticulously, avoiding any injury to the neural plexus here. The IMA and the IMV are then grabbed by the assistant graspers to create the so-called popular Seagull sign. The yellow shaded area here represents the fibrofatty lymph node bearing tissue, which has to be removed completely to ensure oncological adequacy. The nodes at the root of the inferior mesenteric artery are being removed, and we approach the root. Care is taken to avoid injury to all the entire neural plexus surrounding the root of the IMA. After a meticulous dissection here, we can see the preserved neural plexus around the region of the IMA root. Following a meticulous dissection, the IMA is clipped, not flush to the aorta, but a centimeter or two beyond the root. Medial to lateral dissection is then done in the correct plane, keeping the white line of told in vision. Following the mobilization of the descending colon, now the lateral peritoneal cut is taken. Splenic flexure mobilization is then done to gain enough colonic length for our anastomosis later. Having completed the colonic phase of surgery, we now move to the rectal phase. Anterior rectal dissection is begun by incising the peritoneum just outside the rectovesical fold. As we go deep, care is taken to avoid any injury to the seminal vesicles. The parasympathetic nerves from S2 to S4 along with the sympathetic component from the hypogastric nerve form the inferior hypogastric plexus, which is at risk of injury during this phase of dissection. Care is taken to stay exactly in the region between the denonvillous fascia and mesorectum. The denonvillous fascia is then incised to approach the rectal tube. After completing the anterior dissection now, the lateral dissection is started. During this lateral dissection, care is taken to stay just outside the mesorectum and not towards the lateral wall to avoid any injury to the neural structure. Dissection on the right side is then followed by a lateral dissection on the left side. Here we can see that by meticulous dissection we ensure taking only the supply of the rectum and not of the remaining pelvic viscera. Having done the lateral dissection on both the sides, we now approach the remainder of the posterior dissection. Here we can nicely see the two hypogastric nerves and the S2 to S4 sacral nerves. We continue this posterior dissection till we reach the pelvic floor. A thorough and complete defattening of the rectal tube is done on all the sides, ensuring an adequate longitudinal margin. The rectal tube is stapled off using an endostapler. Now, after the removal of the specimen, we can clearly see the two hypogastric nerves medial to both the ureters, and then the S2, S3 and S4 nerves on both the sides. A stapled coloanal anastomosis is performed using a circular stapler. The final.
We could do the same thing with robotic in a slightly faster thing. So the robotic good thing, you got a good high definition 3-dimensional view. And you can see that you have 6 degrees of freedom of the instruments there. You also have the camera in your own arm as well. The same TMA which was done in laparoscopy can be done with robotic. You have slightly for dissecting in the intersphincteric plane. You see the levator very well. If the V of the levator comes up, that's almost the anal hiatus. The advantage of MIS is you can see all these denonvillous fascia very clearly, and views are very good. In fact, in the color 2 trial, for low rectal cancer, the outcomes for laparoscopy were much better compared to open surgery. They didn't have really that good results for mid-rectum, but the number of cases were relatively less. So this is a tumor-specific mesorectal excision. You can go low down there. And once you've done it, you can do a flexible sigmoidoscopy to localize the lesion. Localize the lesion and then finish it. You could sometimes do a bit more. You could sometimes do an extended resection as well. So if you had some disease going into the prostate, the robot has an advantage that you could do a prostatectomy as well. So here again, it is a robotic thing where you dissect initially the vein. So our standard approach is to dissect the vein first and then the artery. So once you dissected the vein, we do the same thing as an artery. So the procedure is the same. There's no difference between robotic and laparoscopy. The control is slightly more. So if you're doing it for male patients and obese, the views are slightly more and the advantage is there. I think the splenic flexure and all these things can be done with laparoscopy as well, but better to get used to the system. So again, the same approach, approaching the root of the IMA. Here, because you're doing the APR, you may want to preserve the left colic. So you take the IMB there, and you can preserve the left colic up there and take the superior rectal. So robotics slightly more expensive, but for complex procedures and where you have a risk of conversions. I think we do quite a lot of MI surgery, maybe as much as 600 laparoscopic surgeries per year. So the conversions are very less. So we use the robot mainly for complex procedures like this. So first you finish the posterior plot completely. So to make sure the mesorectum doesn't get damaged, you can use a gauze piece so that you're not touching it directly. You go down to the pelvic floor. So the anterior CRM in rectal cancer is always a pattern for concern. As you can see, you can take the rectum off posteriorly and laterally so that all the nerves are completely free. So very important, sometimes when you dissect, you try to go only posterior and don't dissect it circumferentially. So here you can see that the dissection has gone down to the pelvic floor. It is also separated from this 2, 3, 4 nerves. So you're not operating in a halo. I think you should always have a good space to operate in the pelvis. Once you've done that, you mobilize it laterally. And for the finer dissection, I think to take the seminal vesicle.
नटेला अंदर ना जाए चॉकलेट सॉस जाए आणि जगह काचे बुराने दे.
So we dissect the ureter. Until you reach the vas there. So you can see vas difference is just above the ureter there. You transect the vas difference and take the seminal vesicle. And what we realized, if you wanted to put anterior dissection, if you separate it completely laterally, then the anterior dissection becomes easier. So after defining the ureter, all the lateral dissection is done. In fact, in this case, from the lower part itself, you're separating the seminal vesicle from the rectum. So plan, this is the tumor which is invading the prostate. So the plan is to do a prostatectomy. And we're also invading the levator and urethra. So we'll just take out the prostate and the urethra and do a suprapubic catheter. So it will be sort of bladder sparing exentrations. So we do a lot of exentrations in a MIS approach, maybe probably the largest series in the world as well. So the advantage of robotic is you have really good control. You can do extended resection. There is less blood loss. And sometimes the dissection is just slightly finished. So you can come back again on the right side here. Because you've done most dissection from the left side, you can pick up the vas there. And then do the anterior dissection. So normally TME, you will go in, you leave the seminal vesicle on the bladder. For this one, you will take the seminal vesicle down till you reach the denum villus fascia. So the seminal vesicle is completely attached to the rectum and the bladder is free. So I think for locally advanced rectal cancer, you have to be just more than a colorectal surgeon, some urology, some gynae. Because contiguous organs excision is required. So once you mobilize the seminal vesicle anteriorly, then you can go get the bladder down. You can take the middle rectal vessels as well. So the rectum is completely mobilized along with the seminal vesicles to the pelvic floor. Here we have a cut in the diaphragm. Once you do that, then the next thing you do, you cut the rectum off, because that is going to be an end stoma there. And then we push the bladder down. They go in the base of resius. You cut the puboprostatic ligaments. And then you lift the prostate off. And what you do is you actually cut the neck of the bladder so that the prostate comes out with the specimen. So what is going to happen, the prostate is going to go with the rectum. You will close the bladder neck and put a suprapubic catheter. So some people after doing a prostatectomy could also join the urethra, but here most of these lesions are very low and they involve the sphincter and the urethra as well. So for this, probably we would just cut the bladder off completely, leave the prostate there. Add the neurovascular bundle, which will be cutting there. Then you close the neck of the bladder. And you make a suprapubic catheter. What it does is you avoided a total exentration. You don't require to make an ideal conduit, and the patient can remove the suprapubic catheter and one colostomy. The rest of the operation and the rectum is taken out from the bottom end, and these people do quite well actually. So I think last year we operated about 1,200 cases, about 600 MIS resections, conversion rate for 1.5%. So almost for all the rectal cancer resections, more than 95% are done in MIS procedure. Thank you very much.
Thank you so much, Prof. Saklani, for that presentation and those videos. I mean, it's always quite an honor to see the precision and the excellence in terms of the skill of the minimally invasive approach that you guys employ, whether it be in person or even I know you post a lot of teaching videos online. So thank you so much again for that presentation. Before moving on to our final presentation, just like to see if there are any questions. We'd like to entertain questions for Prof. Saklani at this time. Okay, we'll move on. Prof, thanks so much. Good seeing you again.
Thanks, Amil. Good to see you again. Bye-bye. Okay. Take care.
So as we move on now to our final presentation, I mean, from various presentations, especially Prof. Sirivadina's talk, we would know that the unfortunate reality of HPB surgery is sometimes oftentimes actually patients will present at a stage where surgical intervention will just not cut it. It's at these times that we as surgeons have no choice but to look to a higher power in order to achieve the best outcomes for our patients. So this is where individuals such as our next and final speaker are called upon to perform what can sometimes only be explained as modern-day miracles. Dr. Nazrin Bim is a clinical and radiation oncologist trained at the University of Cape Town, South Africa, in the management of cancers using chemotherapy, radiation therapy, and brachytherapy in adult patients, and also radiation therapy in pediatric patients. A special interest include brachytherapy and stereotactic radiation therapy, in which she is currently pursuing advanced training at the prestigious MD Anderson Cancer Center in Houston, Texas. She will deliver today's final address with a talk on the role of radiotherapy in the management of liver tumors. Welcome, Dr. Bim. Thank you.
Good morning, Amiel. Good morning, everyone. Thank you, Amiel, for that introduction. Are you seeing my screen?
Yeah, I'm seeing you and hearing you well.
Sorry, 1 second. Okay. Today I have the pleasure of presenting on the role of radiation therapy in the management of liver tumors. I have no disclosures. So historically, pre-1990, radiation was delivered using 2D techniques and a cobalt machine. At this time, little was known about the tolerance of radiation to the liver. And over time, multiple studies involving radiation therapy to the whole liver emerged. The tolerance dose to the whole liver was found to be approximately 30 gray, and this dose was not found to be high enough to result in tumor control, and hence radiation therapy to the liver did not result in favorable outcomes. Within the 1990s to 2005, partial liver irradiation emerged. As more information was gained, building on the surgical principles and the knowledge of functional anatomy of the liver, this data was extrapolated to conclude that ablation of certain portions of the liver could be possible, provided that the rest of the normal liver tissue was not damaged. However, at that point in time, there was still limited information about liver tolerance and the inability to deliver conformal radiation therapy. From 2005 to the present, huge strides have happened in the radiation oncology world. We now are able to deliver highly conformal techniques. We have advanced motion management and tumor tracking possibilities, and there's a lot more studies and publications about liver tolerance. Regarding HCC, there are certain advantages of radiation therapy. One is that it could technically target larger tumors. The treatment is non-invasive, and that's important in patients with advanced liver disease who may have coagulative dysfunction. And it can also target tumor thrombus. But still, one of the most feared complications of radiation therapy is radiation-induced liver disease. It usually occurs 1 to 2 months after the completion of radiation therapy, but rarely more than 6 months after. The risk factors are higher Child-Pugh score, higher volume of liver irradiated, and the higher dose of radiation prescribed to the liver. The symptoms are fatigue, abdominal pain, and hepatomegaly, and there are 2 types, classic and non-classic. The non-classic is more common, often presented with jaundice and very high serum transaminases. And as technology evolved, we now have conformal irradiation used in multi-leaf collimators, complex computer planning systems. We know a lot of information about tumor control probability and normal tissue complication probability. And there's also the emergence of stereotactic radiation. We have immunotherapy, immunomodulated radiation therapy, VMAT techniques with image guidance and motion management techniques. And what that translates to can be seen in this image. The first image on the left shows a radiation plan using 3D technique. So 3D radiation therapy uses fixed beams at 3 to 4 different angles which intersect within the treatment target to achieve a high dose. You can see the high dose in this diagram being more towards a red color, while the blue color represents the cooler dose, the lower dose. And you can notice as well that a lot of the liver is covered with the low dose of radiation treatment. As Though it's improved as compared to previous techniques such as 2D techniques, which was used a long time ago, there's still significant spillage using 3D RT into the normal tissue. IMRT and VMAT techniques further improve this conformality, thus resulting in us giving a higher dose to the tumor target itself and also minimizing spillage into normal tissue around, while SBRT makes it even more possible for us to escalate the dose. And from this diagram at the bottom, you can see that this red area here is even hotter than in the other techniques using conformal radiation with a much narrower dose spill-off and also a much lower distribution of the low dose region. In order to guarantee precision, several factors need to be controlled. One is the interfraction variability, and that is controlled using rigid immobilization to ensure that the patient is in the exact same position every day, and image guidance with X-ray beams, cone beam CT aligned to soft tissue, or even fiducials in some cases, which help to verify the position of the target before delivering treatment. The rigid immobilization devices also ensure that the patient's position is stable during the delivery of treatment. Motion management techniques such as abdominal compression helps to limit movements of the liver during respiratory excursion, and the beam delivery is also timed to specific points within the respiratory cycle to further minimize the movement of the target within the liver. A lot of work was done regarding the dose delivery to the liver. So this study was done by Dawson et al. And was crucial in determining the liver tolerance dose to radiation when using standard fractionation. In this study, 203 patients who presented with focal liver irradiation were examined. 19 of those patients developed RILD. The study found that there was a strong volume effect for radiation-induced liver disease, and there was a correlation of normal tissue complication probability with the mean liver dose. In this study, no patient who received less than 31 degrees of radiation as a mean liver dose had radiation-induced liver disease. So moving on now to the radiation indications in liver cancers. We know that the combination of these technological advances, as well as the increased information regarding tolerance of the liver, now allows us to use radiation therapy safely in patients who have liver cancers without increasing normal tissue complications. In hepatocellular cancer, according to the NCCN guidelines, radiation therapy is indicated in patients who have locally advanced tumors, as well as patients who have potentially resectable tumors but are not ideal candidates for surgical resection. There's a difference in the transatlantic approach, as the European guidelines does not recommend radiation therapy except in early hepatocellular cancer as a non-standard alternative treatment. However, there are multiple studies, both prospective and retrospective, using 3D CRT and IMRT in tumors of various sizes, looking at response rate and overall survivals that shows benefit. A lot of these studies coming out of Korea and Japan. Regarding RT for HCC, there's a study done by Dawson et al. In which patients receive 60.75 gray and 1.5 gray per fraction twice per day, along with concurrent chemotherapy via the hepatic artery. The mean survival from the study was 15.8 months, and the 1 year local control was 81%, with a 1 year overall survival of 57%. Only one patient had a radiation-related death, and 9% of patients developed grade 3 to 4 toxicity. Another study, which was a French phase 2 trial, by Monex et al., which was published in 2006, looked at 66 gray and 33 fractions, and the 1 year local control rate in this study was 76%. In this study, most of the patients who had Child-Pugh score B disease had a 22% risk grade 4 toxicity. From these studies, we found out how a lot of patients who actually have Child-Pugh A and B less than 8 have a relatively good chance of avoiding radiation-induced liver disease once it is that the mean liver dose is kept below 30 gray. A third study by Skinner et al., published in 2011, looked retrospectively at patients receiving a median dose of 50 gray. Again, the 1 year overall survival was relatively reasonable, with 56% of patients having overall survival. And field progression-free survival was higher. It was approximately 79%. The grade 3 toxicity again was very low. And what was then significant from these studies is that it was found that patients who receive a higher dose had a better overall survival. Again, there are also multiple studies of stereotactic body radiation therapy for hepatocellular cancer. And from these studies, we know that the 2-year overall survival ranges from 59 to 100%, depending on the size and dose of the tumor. And most patients who have tumors less than 2 centimeters have a nearly 100% of local control. The higher the biological equivalent dose, the better the local control and overall survival. And basically a biological equivalent dose more than 100 results in the best results. The RTOG 1112 trial is looking at the addition of stereotactic radiation therapy to sorafenib. It has finished accrual and we're awaiting results, but we hope that this gives us favorable information regarding the additional role of SBRT in patients with unresectable and locally advanced tumors. Another study now, we're looking at the use of radiation therapy in neoadjuvant treatment in patients with portal vein thrombosis, was conducted by Wei et al. And published in Journal of Clinical Oncology in 2009. Most patients who do have portal vein tumor thrombosis are not candidates for surgical resection, depending on whether you're using the Eastern or Western approach. This study was a randomized control trial looking at 164 patients with resectable HCC and portal vein tumor thrombosis. And in this study, the radiation therapy used with the older 3D conformal techniques. However, motion management and image guidance was used to improve tumor accuracy and location. The primary endpoint was overall survival. And from these results show a significant benefit for neoadjuvant radiation therapy versus surgery alone at all time points for overall survival and disease-free survival, with the 1-year overall survival being 75% in patients receiving 75% in patients receiving neoadjuvant radiation versus 43% in patients receiving surgery alone. The 2-year overall survival, again, was approximately 3 times higher, with patients who received neoadjuvant radiation therapy having an overall survival of 27.4% versus 9.4% in patients who received surgery alone. So in conclusion, from this study, we know that neoadjuvant radiation therapy is effective in improving overall survival and disease-free survival rates in patients who have HCC and portal vein tumor thrombosis. So in summary, regarding HCC, patients who surgical resection is the sole curative modality. However, radiation is safe and effective definitive treatment of inoperable HCC, as well as patients who are not ideal surgical candidate. The local control and overall survival are dose dependent, with higher doses being able to deliver a longer control rate. And we also know that SBRT is safe and effective for patients with inoperable HCC, again, in patients who are not suitable candidates for local therapies. There's also been demonstrated a benefit for neoadjuvant chemoradiation therapy in patients who have HCC with portal vein thrombosis, and the outcomes in terms of overall survival and disease-free survival are better than surgical approach alone. Moving on now to the use of radiation therapy in cholangiocarcinomas, we see that the results in the guidelines within the European population and the American guidelines are both the same, where radiation therapy is indicated in patients who have unresectable and metastatic tumors. And again, also in the European guidelines, patients who have locally advanced and metastatic tumors. For extrahepatic cholangiocarcinomas, radiation therapy is indicated as adjuvant treatment post-resection in some cases, as well as in patients, as well as definitive treatment in patients with unresectable tumors. The evidence for the use of adjuvant treatment comes from the SWOG 0809 trial, which is a phase 2 trial involving 79 patients with extrahepatic cholangiocarcinomas or gallbladder cancers post-resection. Patients with pathological T2 to T4 disease, node positive or R1 resection, were randomized to treated with standard of care chemotherapy times 4 cycles. Following chemotherapy, patients who had no progression were given chemoradiation therapy. The primary endpoint was 2-year survival, and patients were analyzed as a group as well as grouped into R1 or R0 resection. From these results, we see that the 2 years overall survival was 65%, and the 2-year for all comers, and the 2-year overall survival for patients with R0 was 67% compared to 60% for R1. The median overall survival was 35 months. Regarding toxicity, the risk of grade 3 and grade 4 adverse events were 52% and 11% respectively, with only one patient having a grade 5 toxicity, which was duodenal hemorrhage. So in conclusion, this treatment was tolerated well, with 86% of patients completing the planned treatment, while 10% of patients did not receive radiation therapy due to tumor progression. The survival was significantly higher than expected, with low rates of local failure and an acceptable toxicity profile. So overall, this justifies the use of adjuvant radiation therapy for extrahepatic, hepatocellular, extrahepatic cholangiocarcinoma and gallbladder cancers for patients with pathological T2 to N4, T2 to 4, N positive, and R1 tumors. So again, regarding cholangiocarcinomas, in conclusion, regarding unresectable cholangiocarcinomas, the management is usually first-line systemic therapy, which is according to the ABC-02 trial, and consolidative radiation for patients who have no or low volume disease after progression of treatment. So this is the ABC-02 trial, which was a phase 3 randomized control trial. And I'm not going to get into the details of it, except to show that it demonstrates the superiority of cisplatin gemcitabine over gemcitabine in systemic treatment, which is now adapted as a standard of care for unresectable biliary tract cancers. But I'll point your attention now to the consolidative radiation therapy. The evidence comes from a study done by Tao et al., which was published in the Journal of Clinical Oncology in 2016. This study looked at 79 patients with unresectable intrahepatic cholangiocarcinoma treated with definitive radiation therapy. The radiation was delivered by multiple techniques. So some patients received 3D CRT, some patients received IMRT, and a few patients also received proton therapy. And there was the availability of motion management as well as image guidance. The overall survival and local control were the outcomes being examined. And with this study, several different fractionation regimes were used, but all of them was standard fractionation. So this is not SBRT. From this study, patients were analyzed in 2 groups: those who received a biological equivalent dose of more than 80 gray, 80.5 gray, and those that received less than 80.5 gray. For all comers, the 3-year overall survival was 44%. Radiation dose was the single most important prognostic factor, with higher doses being correlated with improved local control. The 3-year overall survival rate for patients receiving biological equivalent dose of greater than 80.5 was 73% versus 38% for patients who received lower doses. And the local control rate was also significantly higher, being 78% after a BED of 80.5, as opposed to 45% in patients receiving lower doses. So in conclusion, we know that how for consolidative radiation therapy, after chemotherapy, patients who receive the highest benefit if they are able to have a higher biological equivalent dose, particularly if that dose is more than 80.5 gray, one's normal tissue constraints can be respected. So overall, in terms of cholangiocarcinoma management with respect to radiation therapy, we can use for, as I said, neoadjuvant radiation therapy. Adjuvant radiation therapy following surgical resection in patients with advanced tumors. And the data from the SWOG 0809 trial can be extrapolated to the IHC, where patients with positive margins and positive lymph nodes can also have adjuvant gemcitabine-based chemotherapy, followed by radiation therapy with an overall benefit. And also in patients who have unresectable tumors, there's a benefit for patients receiving radiation therapy. And again, this is standard fractionation radiation therapy that the data supports, not SBRT, and I'll get into that in a little bit. Now I'd just like to talk about liver metastases. So the general approach for liver metastases is that if they're resectable, we take them out. If it is that they're not resectable, but the patients have a favorable outcome, then we consider locally ablative procedures. And for patients who have diffuse disease, then alternatives such as systemic therapy or palliative radiation therapy for symptom control or best supportive care can be offered. Regarding oligometastatic disease, this is an intermediate state between localized and systemic metastasized disease. In the absence of phase 3 trials, early clinical studies show that these patients have an improved survival when radical local therapy is added to systemic therapy for oligometastatic disease. There's no existing biomarker for identification of patients with true oligometastatic disease, and hence the diagnosis is based solely on imaging findings. Local control of liver metastases by the use of SBRT has demonstrated favorable results, ranging from 70 to 100% at 1 year and 60 to 90% at 2 years. This outcome is largely dependent on the tumor volume, prior therapy, and radiation therapy dose being delivered. SBRT, the mean overall survival following SBRT ranges from 10 to 34 months, with 2-year survival ranging from 30 to 83%, and several long-term survivors. So again, for oligometastatic disease, because there's frequent out-of-field metastatic progression, one of the considerations has to be adding systemic treatment to SBRT to improve outcomes in these patients. So this study, published in the Journal of Clinical Oncology in 2009, was pivotal in helping us determine the dose of SBRT that can be safely delivered. So this is a phase 1 and a phase 2 trial enrolling 49 patients who had 63 lesions, which were treated 1 to 3 lesions maximum, and a maximum tumor size of 6 centimeters. These patients received 3-fraction SBRT. In the phase 1 trial, the dose was escalated from 36 gray to 60 gray, and then in phase 2, these patients received 60 gray in 3 fractions. The primary endpoint was local control, and we were able to use the information from the study to be able to determine the normal dose tolerance to the liver, as well as the tolerance to the surrounding tissue. And the results of the study showed that the 2-year local control rate was 92% and 94% for patients treated with 60 gray. The local control decreased with larger tumors, and hence when the size was compared, patients who had tumors greater than 3 centimeters had a 77% local control compared to 100% in patients who had tumors less than 3%. And overall, there was no high-grade toxicity, with the risk of grade 3 toxicity being only 2%, and no patient experienced radiation-induced liver disease. This other study, conducted by Chang et al., published in 2011, also looked at the dose for radiation therapy, stereotactic radiation therapy, and compared the patients receiving a dose of 42 gray to those receiving a dose of less than 42 gray, and again, the biological equivalent dose of more than 75 with less than 75. And again, you see better outcomes in the patients who received higher doses with a 1-year local control rate of 90%. The second study, conducted by Ori et al. In 2021, was a meta-analysis of stereotactic radiation therapy for primary or metastatic liver tumors, including 13 studies. And in this, the BED of 100 gray showed significantly improved local control rate versus a BED of less than 100 gray. And the 3-year local control rate was 73% versus 65%. So in conclusion, regarding liver metastases, the treatment remains highly individualized, with patients who are resectable being great candidates for surgery, and in those that are not resectable, SBRT offering a safe and effective ablative use for patients once the normal tissue constraints are well established and safe. Regarding SBRT, there are many indications now that improve the precision and disease control. We use it mainly in medically inoperable stage, early stage HCCs, also in patients who are waiting for transplant, who are for bridging or downstaging, patients who are ineligible for other local control, patients who may have liver dysfunction and not able to have an invasive procedure, patients with portal vein thrombosis, as mentioned before, and patients who have oligometastatic disease. The patient selection is critical to determining good outcomes. So tumors that are 6 centimeters or less in diameter, tumors that are more than 1.5 centimeters from bowel or stomach, less than 3 tumors, and the ability, most importantly, to spare 700 cc's of normal tissue to a mean liver dose of less than 15 gray. The patient must be able to lie flat And as opposed to conventional radiation therapy, where we can treat patients with Child-Pugh scores of Bs and Cs, we in stereotactic body radiation therapy, the limit is usually a Child-Pugh score of 7. If metastatic, the disease must be limited, and also the life expectancy of the patient must be more than 6 months. The dose is decided based on the ability to adequately treat the tumor while meeting organ constraints. And just a few words on palliative whole liver radiation therapy. This technique is a simple technique without motion management or multiple fractionation schedules exist. The planning and treatment process is not complex and there's no survival advantage. However, it results in significant improvement in symptoms, especially pain, as was seen in 50 to 90% of patients receiving pain control after receiving palliative whole liver radiation therapy, and can also allow for liver recovery, so that allowing the use of palliative systemic therapy thereafter. I'd like to thank the committee for allowing me the opportunity to share these slides, as well as the hepatobiliary surgeons at home and their colleagues who manage most or all of these liver patients, these patients with liver tumors, as well as my colleagues and faculty at MD Anderson. Thank you.
Thank you, Dr. Bim, for what was a very extensive and comprehensive review on the role of radiotherapy in liver tumors. And I think it's quite timely, especially with regards to the fact that a lot of times, you know, just because the patient doesn't or isn't fit for surgery or isn't a candidate for surgery, it's good to know that we have these options here that we could still offer them something. And I know that you have been hard at work trying to get these types of therapy, you know, more commonplace and accepted locally, and we appreciate that, and I appreciate all the effort and you put into that. Thank you so much. Are there any questions for Dr. Bim before we move on? Now I know I saw someone ask, will the seminar be recorded and available afterward? Dr. Bim, I think they may want to take some notes from your presentation, maybe. What we will do is we usually do have them available. We just have to ensure that we got the clearance from all our presenters, and we will have a video available shortly within a week, hopefully. Email most likely will come out to the people who would have registered, and usually once we get permission again from the presenters, we usually would post it on our social media accounts. That being said, if there are no further questions, I mean, I would like to begin thanking you all for attending today, but unfortunately, that isn't my job. This isn't in my job description today. So I'll call on Dr. Greg Padmore, who is a clinical fellow at the University of Calgary, where he has completed a fellowship in HPB surgery and is currently pursuing a fellowship in surgical oncology. Greg, please, would you praise us today and deliver today's vote of thanks? Thank you.
All right. Good morning, everyone, or good afternoon. Thanks again. On behalf of the Caribbean chapter of the America's Hepatobiliary Association, and of course, our president, Professor Shamir Kowich, we would like to extend our sincerest thanks to all of the highly esteemed speakers today, namely Professor Siraranda, Professor De Angelica, Dr. Barrow, Professor Ball, Prof. Shaklani, and Dr. Bim. All definitely who are experts in our field of HPB. Further, we are definitely grateful for the attendance to this conference. At the peak of the attendance, we saw up to 176 participants. So we're very grateful for your participation and making our second virtual conference a success. And finally, many thanks to our sponsor, Brydens, and of course to Mr. Keegan Bainey. He's from the Trinidad and Tobago Medical Association. He pretty much all of his work behind the scenes with the technical aspects of getting this conference organized. And of course, our secretary, Dr. Amiel Ara, who's very instrumental in getting this conference put together. So again, thanks you everyone, and looking forward to seeing you for our next conference, and have a good afternoon.
Thanks, Greg. And as Keegan would have posted on the chat, for all of you who may be interested in claiming your CME credits, because the meeting was accredited by the AACME through the Trinidad and Tobago Medical Association. There will be a feedback form that you would have to, I think, Keegan, you have a link there? Yeah, there's a link here on the chat that you guys could access the feedback form, as well as for non-members of the Trinidad and Tobago Medical Association, because this was, there was no cost attached to this attending this seminar. The CME credits to be claimed would involve a small fee as outlined there in the chat. So that being said, thank you very much. I know these speakers are still on. I guess if they have time and are willing to entertain any other questions, we can do that. But otherwise, thank you so much for attending today. Thank you to all our speakers. Take care and have a good day. Stay safe.